चेक चेक टेस्ट टेस्ट चेक हेलो हेलो चेक चेक कौन सा है दोनों में पकड़ रहा है हेलो चेक 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 टेस्ट हेलो चेक 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 टेस्ट चेक वन चेक टेस्ट तो हेलो गोरखपुर
हेलो।
हेलो गोरखपुर अनम्यूट हो म्यूट करके अनम्यूट करके बात करिए बहुत ज्यादा आवाज आ रहा है तो दे देना उसको हेलो हेलो गोरखपुर
अरे होस्ट अलाउ करने को।
हेलो
हेलो। हेलो। अरे वो होस्ट अलाउ नहीं कर रहे थे इसके लिए।
हाँ हाँ अभी आपको दिया अभी बात करिए जरा
ठीक 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 ठीक। हेलो।
हाँ कंटिन्यू कुछ बात करिए नहीं तो सर को
हेलो।
दे दीजिए
अपूर्व जी कैसे हैं?
सर
हेलो।
बता
अपूर्व जी।
एक एक मिनट सर एक मिनट
इधर
बोला क्या?
अंधेरा क्यों है गोरखपुर में
इधर
इतना?
स्क्रीन स्क्रीन पे नहीं आया अभी।
इधर दिख हाँ बोलो अभिषेक जी, इधर अंधेरा क्यों है गोरखपुर में?
अभी अभी कैमरा चालू नहीं हुआ सर।
अरे हॉल में इतना अंधेरा क्यों है?
चेक चेक
हॉल में लाइट है, मतलब वो पीछे की डिम किए हुए हैं, अभी करा दे रहे हैं। भाई ये
और
लाइटिंग थोड़ा तेज कर दो। लाइटिंग सारी
चेक
तेज कर दो।
चेक
वो कर
चेक
रहा है, तुरंत
टेन
कर रहा है।
टेन
चेक
कार्ड टेन
चेक चेक
कार्ड दिख रहा है, ठीक है, टेन कार्ड
सब
है।
ठीक है। देख लीजिए,
हाँ
बाकी कोई
सब
दिक्कत है तो।
दिख ही नहीं रहा है, वो जो कैमरा है उसको, हाँ जूम आउट, हाँ।
ठीक है
हाँ अभी
अभी।
ठीक है, ठीक है, ठीक है, ठीक है, ठीक है, बढ़िया है,
हाँ
दिख
ठीक।
तो रहा है, बढ़िया दिख रहा है।
ठीक
और
है।
ठीक है, गुड गुड गुड।
बाकी
बाकी तो मुझे लग रहा है सब सही है ना?
अभी स्क्रीन नहीं आया लेकिन।
डिस्प्ले,
ठीक है
हाँ
सर।
डिस्प्ले डिस्प्ले हो जाएगा, रुको, आ गया
ठीक।
रहेगा अभी तक।
नहीं अभी आया नहीं।
वो क्यूआर कोड का कैसे स्कैन करना है ये सबको पता है, क्योंकि
वो हाँ
आप थोड़े
ट्राई कर लिया
बाद
सब
में
लोग,
आए।
ट्राई ट्राई कर लिए, ट्राई कर लिए।
ट्राई कर लिए ना?
अभी कुछ
ओके।
दिखाई नहीं रहा है, वो पोल जब स्टार्ट होगा तब बोल रहे
हाँ हाँ
होगा।
अभी तो कुछ नहीं दिखा दे रहा है, बता रहा हूँ मैं आपको।
ठीक हो गया।
दिल्ली दिल्ली ठीक है, दिल्ली गया, ओके, रांची ओके, गोरखपुर, हैदराबाद, कोलकाता, बेंगलोर। हैदराबाद का हो रहा है, तो ओके हो जाएगा फाइनल। चेन्नई, पटना।
हेलो।
ओके ओके ओके, ठीक है। हाँ
स्क्रीन का देख। अभी स्क्रीन।
इंट्रो पीपीटी, यस। अमित जी। अच्छा।
हेलो। हाँ पुरु जी। अभी दिख रहे हैं आप।
परफेक्ट, ओके।
एकदम परफेक्ट।
बढ़िया। लाइट वही, अभी बहुत लाइट डीम है यार उधर,
लाइट
एक
अभी
तो
करा रहे हैं, बोला उसको।
पता
भाई
नहीं।
लाइट अभी कर रहा है वो। भावेश सर गुड इवनिंग।
गुड इवनिंग।
अभी लाइट करवा रहे हैं, एक्चुअली लाइट थोड़ा डिम है, भी कर देंगे वो।
बैकग्राउंड में मर्ज हो गए तुम।
ऐसे ही है।
हेलो हेलो
नहीं अब नहीं है। अच्छा।
अरे हो
अभी
सकता
ठीक है।
है तो
सर अभी
दिखोगे तुम।
अभी दिख रहा
हाँ
है
अभी
ना?
दिख रहे हैं, अभी दिख रहे हैं, हाँ
हाँ।
हाँ।
तो आगे की लाइट।
चेक चेक
इंट्रोडक्शन पीपीटी।
सर डॉक्टर सर
Hello, hello. Yeah.
चेक चेक चेक
Hello,
चेक
hello. Hmm. Okay, so very good afternoon to the respected doctors. Welcome to the Accord Pediatric Summit 2.0 presented by Alchem Laboratories. So this event underscores our commitment to advancing pediatric medical education across India. So this year's summit features an interactive case-based CME program, which is currently being live streamed to approximately 60 locations across the country with over 2,500 pediatricians participating. So we are honored to host distinguished and eminent faculty from India, including the esteemed Dr. Y.K. Amdekar. Our speakers include Dr. Rajesh Chokhani, who is the chief coordinator for this particular CME program, Dr. Vijay Yawale, Dr. Rajiv Sinha, Dr. Baldev Prajapati, Dr. Kaustubh Mohite. So before Dr. Rajesh Chokhani takes over, I will invite our faculty and our senior Alchem members to join us for the Saraswati Vandana and lamp lighting ceremony. बोलो देखो पहले इंट्रोडक्शन होगा उसके बाद लैंप लाइटिंग होगी ठीक है नहीं नहीं उससे पहले हाँ तो पहले ये रखना ठीक है हाँ उसके बाद इंट्रोडक्शन होगा इंट्रोडक्शन के बाद लैंप लाइटिंग होगी लैंप लाइटिंग के बाद हाँ उसके बाद हम्म
चेक 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 टेस्ट चेक 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 check,
हेलो, आ रहा है आवाज?
India has the highest burden of bacterial infections. As a result,
इधर से
antimicrobial
आ रहा है वीडियो?
resistance has become a major public health challenge. In such a scenario, healthcare professionals place immense trust in the antibiotics they prescribe, especially in proven molecules like cefixime. Since its launch in 1998 as the pioneer brand of cefixime in India, Taxim-O has earned this trust by effectively treating millions of patients across India. And at the heart of this trust lies Alchem's legacy of quality and an unwavering commitment to manufacturing excellence. The journey of Taxim-O begins with the selection of finest quality of cefixime and excipients, ensuring uncompromised purity and potency. From raw material selection and testing to final packaging, Taxim-O is shielded from temperature fluctuations, pressure and dust, ensuring its superior quality and efficacy. Raw material testing. Cefixime undergoes rigorous testing for identity, purity and potency. Advanced analytical techniques ensure that only the highest quality API is used in manufacturing. Once tested and approved, every batch undergoes a meticulously controlled manufacturing process designed to deliver consistent and superior quality. Dry mixing. Cefixime is blended with sodium lauryl sulfate and aerosol 200 in a high-precision blender for 30 minutes. This optimizes drug dispersion, enhances stability, and ensures uniformity in every dose. Lubrication. The mixture is then transferred to the lubrication blender, where talc and magnesium stearate are added and blended for 5 minutes. This step enhances flow properties, preventing sticking and ensuring smooth tablet compression. Consistent performance at this stage facilitates reliable tablet formation, reinforcing the trust that HCPs place in Taxim-O's dependable quality. Compression. The lubricated blend undergoes high-precision compression, adhering to strict quality parameters. Average weight control ensures dose consistency. Thickness and hardness are monitored for structural integrity. Friability and disintegration time are optimized for reliable efficacy. Uniformity of weight guarantees precision in every tablet. Coating. Taxim-O tablets undergo advanced coating processes to enhance stability, improve swallowing ease, and mask any taste. This final layer of protection ensures product consistency, supporting the trust placed in Taxim-O for delivering dependable therapeutic performance. Similarly, the Taxim-O dry syrup formulation undergoes rigorous quality checks to ensure uniform dispersion and flow properties. Trusted by healthcare professionals for ensuring safety and efficacy in pediatric patients, Taxim-O dry syrup meets the highest standards of pediatric care. Packing. The final product is packaged using state-of-the-art technology. This ensures that every Taxim-O tablet, dispersible tablet, or dry syrup reaches patients in its purest, most effective form. Taxim-O has demonstrated dissolution and bioequivalence comparable to the innovator, ensuring reliable therapeutic outcomes. Manufactured in a facility accredited by top international regulatory bodies, Taxim-O consistently meets global benchmarks of excellence. Taxim-O is now available in a technologically advanced authentication strip pack to ensure that every strip is genuine and original, further reinforcing its trust. A legacy of quality, precision and trust is what defines Taxim-O. Because when it comes to fighting infections, it is vital to trust the pioneer. Taxim-O, manufactured with excellence, delivered with confidence, and backed by over 25 years of doctors' trust. India has the highest burden of bacterial infections. As a result, antimicrobial resistance has become a major public health challenge. In such a scenario, healthcare professionals place immense trust in the antibiotics they prescribe, especially in proven molecules like Cefixime. Since its launch in 1998 as the pioneer brand of Cefixime in India, Taxim-O has earned this trust by effectively treating millions of patients across India. And at the heart of this trust lies Alkem's legacy of quality and an unwavering commitment to manufacturing excellence. The journey of Taxim-O begins with the selection of finest quality of Cefixime and excipients, ensuring uncompromised purity and potency. From raw material selection and testing to final packaging, Taxim-O is shielded from temperature fluctuations, pressure and dust, ensuring its superior quality and efficacy. Raw material testing. Cefixime undergoes rigorous testing for identity, purity and potency. Advanced analytical techniques ensure that only the highest quality API is used in manufacturing. Once tested and approved, every batch undergoes a meticulously controlled manufacturing process designed to deliver consistent and superior quality. Dry mixing. Cefixime is blended with sodium lauryl sulfate and aerosol 200 in a high-precision blender for 30 minutes. This optimizes drug dispersion, enhances stability, and ensures uniformity in every dose. Lubrication. The mixture is then transferred to the lubrication blender, where talc and magnesium stearate are added and blended for 5 minutes. This step enhances flow properties, preventing sticking and ensuring smooth tablet compression. Consistent performance at this stage facilitates reliable tablet formation, reinforcing the trust that HCPs place in Taximo's dependable quality. Compression. The lubricated blend undergoes high-precision compression, adhering to strict quality parameters. Average weight control ensures dose consistency. Thickness and hardness are monitored for structural integrity. Friability and disintegration time are optimized for reliable efficacy. Uniformity of weight guarantees precision in every tablet. Coating. Taxim-O tablets undergo advanced coating processes to enhance stability, improve swallowing ease, and mask any taste. This final layer of protection ensures product consistency, supporting the trust placed in Taxim-O for delivering dependable therapeutic performance. Similarly, the Taxim-O dry syrup formulation undergoes rigorous quality checks to ensure uniform dispersion and flow properties. Trusted by healthcare professionals for ensuring safety and efficacy in pediatric patients, Taxim-O dry syrup meets the highest standards of pediatric care. Packing. The final product is packaged using state-of-the-art technology. This ensures that every Taxim-O tablet, dispersible tablet, or dry syrup reaches patients in its purest, most effective form. Taxim-O has demonstrated dissolution and bioequivalence comparable to the innovator, ensuring reliable therapeutic outcomes. Manufactured in a facility accredited by top international regulatory bodies, Taxim-O consistently meets global benchmarks of excellence. Taxim-O is now available in a technologically advanced authentication strip pack to ensure that every strip is genuine and original, further reinforcing its trust. A legacy of quality, precision, and trust is what defines Taxim-O. Because when it comes to fighting infections, it is vital to trust the pioneer. Taxim-O, manufactured with excellence, delivered with confidence, and backed by over 25 years of doctors' trust. India has the highest burden of bacterial infections. As a result, antimicrobial resistance has become a major public health challenge. In such a scenario, healthcare professionals place immense trust in the antibiotics they prescribe, especially in proven molecules like Cefixime. Since its launch in 1998 as the pioneer brand of Cefixime in India, Taxim-O has earned this trust by effectively treating millions of patients across India. And at the heart of this trust lies Alkem's legacy of quality and an unwavering commitment to manufacturing excellence. The journey of Taxim-O begins with the selection of finest quality of suffixime and excipients, ensuring uncompromised purity and potency. From raw material selection and testing to final packaging, Taxim O is shielded from temperature fluctuations, pressure and dust, ensuring its superior quality and efficacy. Raw material testing. Suffixime undergoes rigorous testing for identity, purity and potency. Advanced analytical techniques ensure that only the highest quality API is used in manufacturing. Once tested and approved, every batch undergoes a meticulously controlled manufacturing process designed to deliver consistent and superior quality. Dry mixing. Suffixime is blended with sodium lauryl sulfate and aerosol 200 in a high-precision blender for 30 minutes. This optimizes drug dispersion, enhances stability, and ensures uniformity in every dose. Lubrication. The mixture is then transferred to the lubrication blender, where talc and magnesium stearate are added and blended for 5 minutes. This step enhances flow properties, preventing sticking and ensuring smooth tablet compression. Consistent performance at this stage facilitates reliable tablet formation, reinforcing the trust that HCPs place in Taximo's dependable quality. Compression. The lubricated blend undergoes high-precision compression, adhering to strict quality parameters. Average weight control ensures dose consistency. Thickness and hardness are monitored for structural integrity. Friability and disintegration time are optimized for reliable efficacy. Uniformity of weight guarantees precision in every tablet. Coating. Taxim O tablets undergo advanced coating processes to enhance stability, improve swallowing ease, and mask any taste. This final layer of protection ensures product consistency, supporting the trust placed in Taxim O for delivering dependable therapeutic performance. Similarly, the Taxim O dry syrup formulation undergoes rigorous quality checks to ensure uniform dispersion and flow properties. Trusted by healthcare professionals for ensuring safety and efficacy in pediatric patients, Taxim O dry syrup meets the highest standards of pediatric care. Packing. The final product is packaged using state-of-the-art technology. This ensures that every Taxim O tablet, dispersible tablet, or dry syrup reaches patients in its purest, most effective form. Taxim O has demonstrated dissolution and bioequivalence comparable to the innovator, ensuring reliable therapeutic outcomes. Manufactured in a facility accredited by top international regulatory bodies, Taxim O consistently meets global benchmarks of excellence. Taxim O is now available in a technologically advanced authentication strip pack to ensure that every strip is genuine and original, further reinforcing its trust. A legacy of quality, precision and trust is what defines Taxim O. Because when it comes to fighting infections, it is vital to trust the pioneer. Taxim O, manufactured with excellence, delivered with confidence, and backed by over 25 years of doctors' trust. India has the highest burden of bacterial infections. As a result, antimicrobial resistance has become a major public health challenge. In such a scenario, Healthcare professionals place immense trust in the antibiotics they prescribe, especially in proven molecules like cefixime. Since its launch in 1998 as the pioneer brand of cefixime in India, Taxim-O has earned this trust by effectively treating millions of patients across India. And at the heart of this trust lies Alkem's legacy of quality and an unwavering commitment to manufacturing excellence. The journey of Taxim-O begins with the selection of finest quality of cefixime and excipients, ensuring uncompromised purity and potency. From raw material selection and testing to final packaging, Taxim-O is shielded from temperature fluctuations, pressure and dust, ensuring its superior quality and efficacy. Raw material testing. Cefixime undergoes rigorous testing for identity, purity and potency. Advanced analytical techniques ensure that only the highest quality API is used in manufacturing. Once tested and approved, every batch undergoes a meticulously controlled manufacturing process designed to deliver consistent and superior quality. Dry mixing. Cefixime is blended with sodium lauryl sulfate and aerosol 200 in a high-precision blender for 30 minutes. This optimizes drug dispersion, enhances stability, and ensures uniformity in every dose. Lubrication. The mixture is then transferred to the lubrication blender, where talc and magnesium stearate are added and blended for 5 minutes. This step enhances flow properties, preventing sticking and ensuring smooth tablet compression. Consistent performance at this stage facilitates reliable tablet formation, reinforcing the trust that HCPs place in Taxim-O's dependable quality. Compression. The lubricated blend undergoes high-precision compression, adhering to strict quality parameters. Average weight control ensures dose consistency. Thickness and hardness are monitored for structural integrity. Friability and disintegration time are optimized for reliable efficacy. Uniformity of weight guarantees precision in every tablet. Coating. Taxim-O tablets undergo advanced coating processes to enhance stability, improve swallowing ease, and mask any taste. This final layer of protection ensures product consistency, supporting the trust placed in Taxim-O for delivering dependable therapeutic performance. Similarly, the Taxim-O dry syrup formulation undergoes rigorous quality checks to ensure uniform dispersion and flow properties. Trusted by healthcare professionals for ensuring safety and efficacy in pediatric patients, Taxim-O dry syrup meets the highest standards of pediatric care. Packing. The final product is packaged using state-of-the-art technology. This ensures that every Taxim-O tablet, dispersible tablet, or dry syrup reaches patients in its purest, most effective form. Taxim-O has demonstrated dissolution and bioequivalence comparable to the innovator, ensuring reliable therapeutic outcomes. Manufactured in a facility accredited by top international regulatory bodies, Taxim-O consistently meets global benchmarks of excellence. Taxim-O is now available in a technologically advanced authentication strip pack to ensure that every strip is genuine and original, further reinforcing its trust. A legacy of quality, precision and trust is what defines Taxim-O. because when it comes to fighting infections, it is vital to trust the pioneer. Taxim O, manufactured with excellence, delivered with confidence, and backed by over 25 years of doctors' trust. India has the highest burden of bacterial infections. As a result, antimicrobial resistance has become a major public health challenge. In such a scenario, healthcare professionals place immense trust in the antibiotics they prescribe, especially in proven molecules like cefixime. Since its launch in 1998 as the pioneer brand of cefixime in India, Taxim O has earned this trust by effectively treating millions of patients across India. And at the heart of this trust lies Alkem's legacy of quality and an unwavering commitment to manufacturing excellence. The journey of Taxim O begins with the selection of finest quality of cefixime and excipients, ensuring uncompromised purity and potency. From raw material selection and testing to final packaging, Taxim O is shielded from temperature fluctuations, pressure and dust, ensuring its superior quality and efficacy. Raw material testing. Cefixime undergoes rigorous testing for identity, purity and potency. Advanced analytical techniques ensure that only the highest quality API is used in manufacturing. Once tested and approved, every batch undergoes a meticulously controlled manufacturing process designed to deliver consistent and superior quality. Dry mixing. Cefixime is blended with sodium lauryl sulfate and aerosol 200 in a high-precision blender for 30 minutes. This optimizes drug dispersion, enhances stability, and ensures uniformity in every dose. Lubrication. The mixture is then transferred to the lubrication blender, where talc and magnesium stearate are added and blended for 5 minutes. This step enhances flow properties, preventing sticking and ensuring smooth tablet compression. Consistent performance at this stage facilitates reliable tablet formation, reinforcing the trust that HCPs place in Taxim O's dependable quality. Compression. The lubricated blend undergoes high-precision compression, adhering to strict quality parameters. Average weight control ensures dose consistency. Thickness and hardness are monitored for structural integrity. Friability and disintegration time are optimized for reliable efficacy. Uniformity of weight guarantees precision in every tablet. Coating. Taxim O tablets undergo advanced coating processes to enhance stability, improve swallowing ease, and mask any taste. This final layer of protection ensures product consistency, supporting the trust placed in Taxim O for delivering dependable therapeutic performance. Similarly, the Taxim O dry syrup formulation undergoes rigorous quality checks to ensure uniform dispersion and flow properties. Trusted by healthcare professionals for ensuring safety and efficacy in pediatric patients, Taxim O dry syrup meets the highest standards of pediatric care. Packing. The final product is packaged using state-of-the-art technology. This ensures that every Taxim O tablet, dispersible tablet, or dry syrup reaches patients in its purest, most effective form. Taxim O has demonstrated dissolution and bioequivalence comparable to the innovator, ensuring reliable therapeutic outcomes. manufactured in a facility accredited by top international regulatory bodies. Taxim O consistently meets global benchmarks of excellence. Taxim O is now available in a technologically advanced authentication strip pack to ensure that every strip is genuine and original, further reinforcing its trust. A legacy of quality, precision and trust is what defines Taxim O. Because when it comes to fighting infections, it is vital to trust the pioneer. Taxim O, manufactured with excellence, delivered with confidence, and backed by over 25 years of doctors' trust. India has the highest burden of bacterial infections. As a result, antimicrobial resistance has become a major public health challenge. In such a scenario, healthcare professionals place immense trust in the antibiotics they prescribe, especially in proven molecules like cefixime. Since its launch in 1998 as the pioneer brand of cefixime in India, Taxim O has earned this trust by effectively treating millions of patients across India. And at the heart of this trust lies Alchem's legacy of quality and an unwavering commitment to manufacturing excellence. The journey of Taxim O begins with the selection of finest quality of cefixime and excipients, ensuring uncompromised purity and potency. From raw material selection and testing to final packaging, Taxim O is shielded from temperature fluctuations, pressure and dust, ensuring its superior quality and efficacy. Raw material testing. Cefixime undergoes rigorous testing for identity, purity and potency. Advanced analytical techniques ensure that only the highest quality API is used in manufacturing. Once tested and approved, every batch undergoes a meticulously controlled manufacturing process designed to deliver consistent and superior quality. Dry mixing. Cefixime is blended with sodium lauryl sulfate and aerosol 200 in a high-precision blender for 30 minutes. This optimizes drug dispersion, enhances stability, and ensures uniform.
Hello.
A very good evening to the respected doctors. As I, Dr. Amit Rajit Pal, welcome you all to the Accord Pediatric Summit 2.0 presented by Alchem Laboratories. So, this event underscores our commitment to advancing pediatric medical education in the country. This year's summit features an interactive case based CME program live streamed to approximately 60 different locations across India with over 2,500 pediatricians participating. We are honored to host distinguished and esteemed faculty from India, including the esteemed and eminent personality Dr. Y.K. Amdekar, sir. Our speakers include Dr. Rajesh Chokhani, who is also the chief coordinator for this particular program, Dr. Vijay Yawale, Dr. Rajiv Sinha, Dr. Baldev Prajapati, Dr. Kaustubh Mohite. So before Dr. Rajesh Chokhani takes over, I will invite our faculty and Alchem senior members to kindly join us for the Saraswati Vandana and lamp lighting ceremony. Thank you, and let's embark on this day of learning and collaboration. Yes.
Hello. Hello.
Hello.
It gives me great pleasure to introduce to you our Chief Coordinator for Summit, Accord Summit 2.0, and that is Dr. Rajesh Chokhani, sir, who is a consultant pediatrician, Hinduja Hospital, Mumbai. He has been a president of Indian Academy of Pediatrics 2023, examiner MRCPH, Royal College, UK and DNB, FCPS, DCH exams, and has been an eminent faculty for various conferences at the international and national levels. Welcome, sir. So we'll move on to the first session for today, that is evidence versus experience, balancing proof with practice in pediatrics interactive case-based discussion. And for this particular session, I'm pleased to introduce you to one of our pioneers in the field of pediatrics and an eminent personality, Dr. Y.K. Amdekar, sir. Welcome, sir. He has been practicing pediatrician for the last 50 years. He has been a visiting consultant to SRCC Hospital, Mumbai. He has been a eminent teaching personality and faculty at Grant Government Medical College and Sir JJ Group of Hospitals, Institute of Child Health, Mumbai. And he has also been a past president of the Indian Academy of Pediatrics. Welcome, sir. I will now request our eminent faculties to take over the session. Thank you. Yes. I will now request the Alchem senior personnel to present the shawl and memento to our eminent faculties.
Thank you very much. Thank you. Thank you. Big round of applause to our Thank you, sir, once again. Really honored.
Good evening, friends. As usual, this is going to be an interactive session. So please raise your finger and we'll get it to you. We thought the whole era today is evidence-based. And the question is how often you find evidence, and if you don't find evidence, what do you do? Then use an experience. And I always feel very funny that we arrive on this earth and we leave this earth without evidence. Nobody says, are you be born? Let's have an evidence. And are you dead? Let's have an evidence. No need of evidence at birth and death time, but the evidence all along. It's funny, right? But that's what the modern era is. And at birth and at death, you don't say, let me do the EEG when the brain is dead. No, you are dead. The question is, are we academically dead? And there is no evidence. So we are just trying to see how we can go about this. And I think there is really no divide between experience and evidence. In fact, the both are the sides of the same coin. And a problem arises when we try to differentiate between the two. Oh, are you talking with experience or evidence? Both possibly are the sides of the same coin. And I think evidence in clinical practice is based on tests that offer proof. But tests are also different strengths. Lack of evidence is not the absence of evidence, and evidence may not mean an active disease. So again, there is a problem of evidence. And then experience is a clinical judgment that involves decision making, depends upon appropriate application of knowledge and individual expertise. Need skills, but most important is we must have an open mind to avoid bias. Moment somebody says, sir, you are experienced, you all know the definition of experience. Experience is defined as an ability to make the same mistake again and again with increasing confidence. So that's an experience, and we need to be very, very much open about it. And therefore, I think clinical judgment is the key component of evidence based medicine to our inseparable. So we start finding the evidence only when we clinically decide what way to go further and prove the evidence. And without it, you cannot just have an evidence at all. And with this kind of a thing, we will do the case scenarios, and we want all of you to opine whether you would use experience or evidence, or maybe both. Okay. And let's have a discussion based on actual case scenarios that we have been seeing and making a kind of a discussion possible out of a real stories. Okay, let's see the first case.
Sir, before that, so good evening, everyone. Just to give you an idea, we are connected to 55 or 60 other centers which are viewing this program live. And out of them, 12 other centers will be interacting with us online. So the format will be that once we read out the case and once we have some initial discussion, we'll give the options, and then you have to scan the code which is on your table here. Similarly, all the outstation centers who are connected to us, you know that you have to scan the code and you will be connected to this app. And then when we say that you can start voting now, people here as well as people all over who are connected can start voting using their mobile only. So you have to scan the code which is there on your table, and you will be directly brought into that area where the question is there, and you just have to press 1, 2, 3, 4, whatever as per your choice. So the voting pattern of our local people mixed with the voting pattern of all the 12 centers will be combined, reflected here. We will see those bar diagrams. Then we will invite comments on why somebody thinks one option is right or wrong. Now, for this, to make it an orderly discussion, I will first announce the outstation centers, 2 centers per case. So those 2 centers have to interact for that case, followed by another 2 centers for the next case. And once we take the online interaction, we will come to this local audience and 1 or 2 interaction from here. So this way we will make it a orderly discussion and go through the whole thing, right? So I think for the first case, we will have Bangalore and Gaya interacting with us. Are you there with us, Bangalore and Gaya? Have you registered this? Yeah. So for the first case, you both centers will be interacting with us, and let's be very friendly about all this. So basically, if you definitely have some point to make, definitely make it. If you feel that no, you just don't want to say anything, you can say okay, pass or whatever, and we'll go on to the next one, because it's all a collective learning. So whoever speaks, everyone will learn. So it is not mandatory that we have to say something or repeat something. So that's how we will go about the whole thing, right? Okay. So let's start with the first case, a very, very usual OPD scenario of a 2-year-old healthy child who presented with fever, cold and cough for 2 days. On examination, the child is not sick and there is no specific localization. So with this, the options are no tests, counsel parents. Second option is get a CBC peripheral smear and a CRP done. Third option is get a wider set of fever panel done, which includes SGPT and NS1 antigen and so on. And fourth option is get a multiplex PCR for respiratory infections. Now, mind you, the focus of our session today is evidence versus experience. So, whatever option we choose, we are going to be questioned about if you choose experience, then why not evidence? And if you choose evidence, then why not experience? And we'll have to justify that to get our concepts right. Okay. So with that, your voting time starts now, and all 12 centers, including Mumbai the 13th, can start voting. Okay, we can give some more seconds for voting. People are still voting and the votes are getting registered. Okay. So we can see that the majority have voted for no tests, counsel parents.
Yeah, but majority may not be right necessarily.
Absolutely.
Okay. So let's
So
discuss
yes, sir.
those.
Yeah. So now Bangalore, you can come in. Any one of the attendees at Bangalore can either defend one option, any of the four options, or speak against any of the other options. So anyone from Bangalore? Yes, sir, come in.
I think the A
Oh.
answer is correct because we would just like to observe the child. If you are that worried about this fever, cold, and cough, we can always ask them to come the next day. You can check the child, and if necessary, after 4 days, you can investigate this. Child
Okay.
needs to be observed. That's all.
So, sir, the question is, we are talking of evidence versus experience. So, what evidence do we have just now that this is not a serious infection?
If the child is not toxic looking, we can wait and see.
Okay, fine. Anyone from Gaya wants to add or say something else or talk against any of the options?
Yes, sir.
Yeah, please come in.
Sir, there is a disseminated infection, upper and lower respiratory tract. So it is viral type. And second thing is the child is not sick. Disseminated infection, not sick, cold, cough, and fever is mostly viral infection. So on option 1, no test, counseling is required.
Okay. So now you notice that about 5% of the voters voted for CBC, peripheral smear, and CRP. So what is your comment on that?
CBC should not be done in initial 2 days. Yeah, after 3 days of illness, we must do, and it say something about the illness first. The second thing, PS you can do, but only when the fever is only symptom, then we can suggest the PS for peripheral smear. And
Okay.
CRP is elevated after 48 hours of illness, or it can elevated in viral or bacterial both. So there is no clue to CRP.
Anyone here now? Okay. Most of us agree what we would be doing, but we are concerned. We may be wrong. And if we are wrong, then we will be responsible. In a modern days when everything can have an evidence, how can you judge us by experience? I would put the last one, multiplex, every infection, not even one. You may have 10 of them at one time only. You are safe. Don't you think so?
So the question to all of you here is that all of you think this is mostly a viral infection. What evidence do we have? How can we be sure?
Hello.
That is where experience counts.
Should I say?
Yes, sir.
Actually, the child is not looking sick and there is no localizing signs. So initially we will think of viral fever and unless we get any other evidence or localization or the child looks sick.
Now, as a parent, I
Okay,
ask
thank you, ma'am. Thank you from Patna. Thank you. Now we'll have some local discussion here in Mumbai and wind up.
As a parent, I want to ask my doctor, Doctor, are you sure? Or there could be some problem? Now you say, I'm sure.
Yes.
Sir, at such times, maybe we can tell them that from our experience, this is what we feel, that the child is healthy, not sick, no localizing sign. So this is most likely to be viral. It's been just 2 days. So follow-up is going to be essential so that we know that we are not missing on anything. And if the child worsens, then we can counsel the parents in that meeting itself that there is a possibility. If the child worsens, then we can do tests to prove or disprove if there is any such issues. But generally from say my experience, this is what I feel. And in case there's a very, very apprehensive parent who wants to do everything, then we do have everything.
Why do you wait for worsening? You
Because-
said, if it worsens, I will do something. As a parent, I want you to do something now only.
Sir, because again, the common things happen to common people.
Sir, I will go to the basic factor that I will ask the parents why you are worried. If there is a history of febrile seizure in any other child, or if the same child had febrile seizure, that's why they are worried. So it will require more of a counseling and then the talk.
Today we have a medicine for influenza virus. Okay, this could be influenza. And we should give an antiviral. And thereafter he gets into complication. The court will ask you, did you not know antiviral medicine was available and it could work only initially, but you waited. Now the drug won't work. Good that patient may not understand medicine, but imagine this happens.
So the child is playful, eating and reasonably well. And if there is a family member who also has this kind of fever from he has acquired or any source is known, then reasonably we are sure that this is probably a viral fever and we can wait. And most of the influenza patients don't require medicine. They settle down on its own within 4 to 5
You're right. All of us are right. The question is, mostly you're right. Most of us will be all right, but few may not be all right. No. Am I one of those few? Or you are not worried?
And the other angle to it is, what is the harm in doing those tests and getting proof? So that's the other side. So most of you are saying experience wise, yeah, we agree with you. But what is the harm in doing the tests? So if you convince us that your experience will not let you down, and if you convince us that those tests might let you down, then we will accept that we will do this.
Sometimes, sir, by doing more tests, we might end up causing more anxiety because clinically the child might be stable. But suppose you get a high CRP, and then of course, like nowadays, parents are also Googled parents. So they would think that high CRP is like severe infection. So now give something to my child. So initially in these first 2 days, I would try to convince them out of my experience that it shouldn't be done.
I think all of us are right. You wanted to say something.
No. See, doing test early, you can end up with a false negative also.
And therefore, I think all of us are right in choosing the first option, but more important is how to counsel the parents. You would say that mostly there will be no problem, and in the next 2 days you will be all right. However, if you want to be all right today, we might have to do many tests, and none of the tests is likely to give us an answer. What answer you want? Will he get complicated or will he get better? The answer will not come with any test.
Answer might give you what's the cause. Answer may give you the name of the virus, but it will not tell you what will happen after 2 days. So why spend money? And none of the tests are definitely totally true. Therefore, I suggest you wait. But if you like, we will do the test. This should be the counseling. Majority will believe you and say, okay, we won't. Let's see what happened to this patient.
Yeah. Just one more point. Incidentally, anyone from Bangalore or Gaya, do y'all also do a fever panel which includes SGPT? And if you do, how does it help you in your clinical practice? In a short duration fever of 2-3 days, one of the fever panels, blood tests, include SGPT. Does it help in your clinical practice? How do you, your comments on that? Anyone from Bangalore or Gaya?
Rajesh, is this panel IIP recommended? What is this panel or Government of India's panel?
Okay. I think there are no comments from both these places. Anyone here wants to comment on it? Means we are discussing, does it help in a short duration fever, 2 days, 3 days? If you do a SGPT, does it help you in deciding anything? No. Okay. Now let's see how all of us were wrong. Okay. Okay. So case 1 continued. This child developed fast breathing on day 3. ओके गया ना आमडेकर सर को देख के सब लोग बोलते हैं नो टेस्ट नो टेस्ट नो टेस्ट ऑन एग्जामिनेशन नॉट सिक सबकॉस्टल रिट्रैक्शंस बायलैटरल वीज SpO2 93 options chest x-ray oxygen and nebulized salbutamol and observe. In addition ABG with multiplex PCR. In addition, broad spectrum antibiotic and antiviral, and in addition, ICU admission. And your time for voting starts now. All centers, please scan the code and start voting. Okay. So about 10% would want to start antibiotics and antivirals. About 5% would want to admit in the ICU. And the remaining are okay with less aggressive measures. So now, someone from Gaya, do you want to tell us what is your analysis of what has happened? Some new participant from Gaya wants to speak?
Yes, sir. It still look like a viral infection, and it is.
Okay. We'll come back to you later. Someone from Bangalore wants to speak. What is your analysis of what has happened? Okay. Bangalore, please come in.
The fever has come down, but the infection spread to the lower respiratory tract, causing wheezing. So I think it's a viral infection only. Just observe and nebulization with oxygen should suffice, I think.
Sorry, it was not clear. Can you repeat it?
I think it's a viral infection only, sir. The fever has subsided, but the cough has persisted, and the infection has spread to the lower respiratory tract, causing wheeze. So we require just nebulization and oxygen.
Yeah, but he's tachypnic. He has got retractions. Couldn't it be a viral interstitial pneumonia? His oxygen is 93 in room air.
Could be, sir. Could be.
Could be. So then we can't take a chance. So then we'll have to do ICU admission. Okay. Yeah. Since Patna is also spotlighted, Patna, anybody wants to come in?
Actually, we will go for chest X-ray, oxygen, because the oxygen saturation is less, 93, and we'll start nebulizing the patient because there is bronchi all over. It may
Yes,
develop
madam.
further.
Madam, what is your analysis of the situation? Do you
Maybe
think this?
early
Yeah. Go on, go on.
pneumonia, bronchiolitis.
Okay. Okay, so then this child needs admission, right?
In case of smaller children, of course.
Okay, fine. Anybody here in Mumbai wants to give his or her impression of what has happened? What is your analysis?
Hello.
Probably
Hello.
this is acute bronchitis that has got triggered by a viral infection. The child's fever has already got better. So that is a good sign. So definitely it's not a worsening bacterial or a viral infection in that sense. The child, we must ask for history of wheezing in the past so that, that might help us to decide if this is also a wheeze-associated respiratory infection or an acute episode of asthma. And yes, I would like to observe this child. I'll definitely not send this child back home. And at least admit him in a place where I can shift to ICU in case the child gets worsened. I mean, I'll not put him in a setting where I'm not comfortable without an ICU.
So,
there are seats here, please. Those who have come right here. There are some seats available here. No, I think what you said is absolutely right. First thing is the fever has disappeared, so the infection seems to be dying out. Second is that there is wheezing. A typical acute interstitial pneumonia, the virus would have continued to kind of cause fever, more sickness, and there would not have been retractions of this kind, and there would not be wheezing of this kind. So the anatomy is really the bronchial tree and not the interstitial. So if it's a bronchial tree problem and not interstitial, then possibly a mere oxygen and nebulization with a bronchodilator would improve the child's wheezing very quickly. And therefore, we should first attempt to do that. Anyway, the rest of the test will not tell us what to do. And therefore, I anticipate that in the next 20-30 minutes, with good oxygenation and nebulization, I anticipate this process to start getting better. And if so, then nothing more is required. However, if a chest X-ray has been done to rule out any localizing pneumonia, which is most unlikely, but even that is confirmed, and therefore we will not do anything at all and we will wait. But this, what are we learning here? Evidence is not necessary every time. And an experience alone is not enough every time. Then what else you know? You need to counsel the parents. And therefore, counseling is not an option, whether you want an experience or evidence or both. And today, most of us have no time to counsel. And I think that is very, very important. So let's see what happened to this child.
improved after oxygen and nebulization. So it was a wheeze associated respiratory infection.
Good. I'm sure all of us would agree to this. But we just want us to realize that parents will ask us questions and to which we must have an answer, and to which a good counseling with a good confidence should be necessary. And again, to say the same, no tests are really alternatives to counseling. So I think we must spend time like this. And we don't need so much of time in every patient. But some of them, and especially if the parents are very inquisitive, some of them also want to find out whether you know enough medicine. Okay. So we need to be cautious about that. Let's see the next patient.
Okay. So we will move on to the second case. And this time we will have some new centers who will be interacting with us. So we will have Kolkata and Gorakhpur who will interact with us this time. And then of course, local from Mumbai. So moving on to the second case. Now there are two second cases which are looking very similar, but there will be differences. So at the end of the second case, we will learn what are the differences and why the approach could be slightly different. So this is a 14-year-old boy who presented with periumbilical pain off and on for the last 4 months. Routine tests were normal, treated empirically with drugs, but failed. And on examination, no findings. So your options are, or okay, before that we'll ask you, do you need any more information? So Kolkata, do you want any more history? This is the history that we have given. Do you need any more history? And even Gorakhpur can come in. Do you need any more history? Yeah, Gorakhpur, please come in. After that, Kolkata. One sec. Gorakhpur, come in. Sir, we can't hear you, Gorakhpur. Please speak into the mic. No, we are not able to hear. Okay, Kolkata, you can try. No, we are not able to hear Kolkata also.
Hello.
Yeah. Kolkata, please come in now.
Hello.
Kolkata Center, somebody can speak.
Hello. History of constipation, history of intake of junks, history of intake of cow's milk and others. Junk food, milk, and passage and the passage of stool. Whether there is any history of constipation or not.
Yeah, so there is no history of constipation. Junk food, so he has been eating since he was a newborn. And third question?
Milk. Cow's milk.
Cow's milk. Okay. Yeah, so he's a 14-year-old teenager, so he doesn't believe in milk. He believes in other drinks. But the point is, sir, that the pain is since last 4 months. Okay. Gorakhpur, you want to ask any more questions? Sir, we can't hear you. Is it center muted hai kya? Okay. Okay. We'll come back to you, Gorakhpur. I think there's some reason we can't hear you. Okay, Lucknow has been spotlighted. From Lucknow, anybody wants to ask any more questions?
Yes. First of all, as Kolkata people have already highlighted, we have to take the history
Sir,
of
don't
constipation.
repeat that, please. Please don't repeat that.
Okay, then we have to see the social history, family history, what is his behavior in school, and other things which may be associated with.
Yeah, so the school, the only problem is that in his last exams, he got only 99.9% and his mother was not happy.
Excuse me, it seems to be functional pain. It seems to be functional pain because there is no problem as the last 4 months. The child is still going fine and all the drugs have been failed. So it's supposed to be a functional pain only. This is psychosomatic.
Okay, we'll come back to you, sir, in 5 minutes. Any other questions? Yeah.
Hello.
Any blood in stool?
Any blood in stool? No.
Hello. Any vomiting?
We would like to have details on how the pain is, whether it is dull aching, shooting, whether it is located to a particular spot or is it radiating. It's a big child. He can describe the pain. Is it before food, after food? And what medicines have been given which have failed? And is there any associated vomiting, loose motion intermittently which is coming and going? And what routine tests are normal? I don't get that. Yeah.
Rajesh here.
Excellent.
See, want to know what time of the day or night pain is there. If the sleep is disturbed due to pain, I'll go in more investigation. During daytime and subsides with what? And that's it.
Sir, one last one here and then we'll give the options.
So severity of pain, whether pain is affecting daily routine activities and as ma'am said, night awakenings, pain causing night awakenings.
I think all of you are right. What we want to stress is if the disease is going on for a long time, the first and the only question to begin with is how is his health maintained? And health includes all that you are talking about: sleep, behavior, bowels, urine, Okay, everything.
So I'll give you the answers. No other complaints. No vomiting, no loose motions. Sleep is not disturbed. The pain is of very average intensity. Is continuing to do all his activity. There is no change in his activity. Okay. Now with no weight loss. Now with these answers and history that you have taken, your options are endoscopy to rule out inflammatory bowel disease and celiac disease, tests for H. pylori, MRI or MR angio for of the abdomen, or consider a functional disorder and counsel parents. Remember, all of us had gone wrong in the first case, so be careful.
Hello.
So your time to vote starts now, and you can start voting. All centers also start voting. Okay, fine. So majority want to consider as functional disorder, but some do want to do endoscopy. So from Gorakhpur, anybody wants to discuss about whether we should do endoscopy or not do in this case? You want to argue for or against? Anybody from Gorakhpur?
Sir, there is no weight loss, no sleep disturbances. So this child, I think, doesn't need endoscopy, and it should be considered a functional, and parents should be concerned for this.
Okay, sir. Okay. Anybody from Kolkata wants to add or differ?
Hello, sir.
Yeah. Yes, sir.
Abdominal pain may be of two types, whether it is inflammatory, infective, or non-inflammatory. In this case, there is no sign of inflammation or infection. So other causes of pain may be neurogenic, may be vasogenic, may be psychogenic, may be referred. Here in this picture, we find that all the findings lead to the psychogenic pain.
Okay, sir. Thank you.
Well, I think all of us agree that the way to counsel really is that it has been going on for a long time. Even then, the child is maintained his routine activities. There is no loss of weight, and therefore, we could go by experience for a while to confirm that he's going to be all right. The question is, now we are all said that it's a functional disorder. The test for H. pylori is not dependable at all. Every one of us has some antibodies against H. pylori. It doesn't mean anything at all. Why MRI, etc.? We're not expecting some abnormal vessel compressing somewhere. It would be an acute vascular pain. So that is out of question. And therefore, even in endoscopy, there would be some pain as a major factor, which is disturbing them. And therefore, we explain to them that this problem has been static and not worsening for last 4 months. Therefore, we have time on hand. Most of the tests will not reveal the answer, and therefore we will wait. But the question is, what do we wait? What do we do for functional problem? Wait is all right. Sir, we have waited for 4 months. So don't you want to give treatment?
Do an ultrasound abdomen?
Yeah. Should we do an ultrasound abdomen?
Ultrasound or even a basics like a urine examination.
Yeah, so somebody asked what routine tests were normal.
Yeah.
So CBC, urine stool, CRP, all those things were normal. And what treatment was given? He was dewormed 6 times in 4 months because every doctor thought that I am the first one and the most brilliant. So that was plus anti-amoebic antibiotics, etc., etc. Okay. So USG, sir, should we do a USG?
I think USG is for a structural problem, and we are discussing a functional problem. For example, H. pylori is a functional problem, means not psychogenic, but the function is disturbed. So ultrasound will not, but ultrasound is a simple test, harmless test, cost-effective test. Parents are happy. But you will have to counsel the parent before you ask for USG, because USG will always say the bladder wall looks little thick, there are some lymph nodes there, and therefore your problems are increased.
And there is minimal fluid in the pouch of Douglas.
And then it will say correlate clinically. Okay. So we will have to again counsel on all that. Question is, what do you do for such a patient? He has to be all right, no? Functional or non-functional. What do you do? Refer to psychologist, refer to psychiatrist.
He's an adolescent. So there could be some issues that could have been worrying him, and he could be coming up like this with a psychosomatic problem. So I would like to counsel him in detail about what is his scenario at like relations with parents, with friends. Are there any other issues that are troubling him? What are the trigger factors for those pain, and how do they get all right? Would they just, according to him, whether does he feel that it would just get all right on its own? So first and foremost, I would like to counsel the child rather than, just come up with talking to the parents.
Very good. So I think she summed it very well, that problems could be lying everywhere, maybe at school, maybe with friends, maybe with family, etc. And you may have to tell the parent that it's difficult for you to accept this, but be sure that there is some trigger of this kind, and I want your observation to guide me. And there will be no test for that. I think we'll have to, I'm sure time and again we have seen best of the people not accepting this diagnosis, but come again after a round of several tests and then ask them, now what do we do? But you don't refer to psychologist or a psychiatrist, or you are good enough.
I'm not good enough, but at least an initial counseling with the adolescent will develop some kind of a rapport, and maybe it might give me some insight whether he would benefit from a. So, but I have one thing. One is about constipation. A lot of these patients with constipation, especially with the kind of junk food that children eat, may come like this. So, I would definitely go into
Yeah,
the
that's
details.
agreed. There's no
And
debate
one
on
more
that.
thing, if this child goes to a GI pediatric, he will surely get an endoscopy done. So how do we, I mean, I'm sure after I counsel the parents a number of times saying this function, they'll surely go to a pediatric gastroenterologist and he will surely go ahead and do an endoscopy.
And he will prove you right. He will prove you right. And the endoscopy will not get anything. Yeah, that's fine. We are just trying to say that so far, none of the cases you wanted any evidence. In a modern era of evidence-based medicine, we are all agreeing, go by only experience. Something dangerous, right? Let's see the next one.
Let's see the next one.
Yeah.
Yeah. So again, it's a 14-year-old boy. Sorry, this is
No,
so
next
this
one.
was functional pain.
Yeah.
Sorry, and next one. So this is a 14-year-old boy who presented with lump and back pain off and on for the last 4 months. CBC, urine routine, stool routine, USG were all normal, and as usual, deworming, antibiotic, antiamoebic course did not help. And on examination, there are no findings. So again, you would probably ask the same questions. So there are no other symptoms. So no vomiting, no loose motions, the activity is not affected, etc. So more or less the answers are the same. There's no change in the.
There is nothing at all. Okay. In fact, when I asked this boy, he said, I'm not allowed to go out and play because they feel that when I go out and play, my pain increases. And all he wanted was to go out and play. So I said, first let him go out and play. Let's see how bad it is. But the pain did not change. Pain did not improve nor got worse. Do you suspect something wrong in that statement before we go further on that?
Sir, we'll give the options and then we'll discuss. Okay, so again, your options are endoscopy to rule out IBD and celiac disease, repeat USG, CT abdomen, or consider a functional disorder and counsel parents. So everybody from all over the centers, please start voting, and locally, of course, please start voting. Scan the code which is there on your table and start voting.
Well, at least there are two equal parties. I was worried what's happening to the government. No opposition party. That's bad. Yeah, yeah.
So now, Varanasi, you can come in and you can tell us any comments from your side on why you choose any particular option. Anybody from Varanasi? Okay, anybody from Gorakhpur wants to talk? Anybody from Lucknow wants to talk?
Repeat USG.
Okay,
And
sir.
if that comes out to be normal, then CT abdomen.
Okay, give us your reasons why you think that.
You see, in the first, because it is a lumbar pain and back pain, one thing we must rule out that there is no school bag or there is no orthopedic problem which is leading to back pain. And once we have ruled out that, then repeat USG might reveal something pertaining to KUB system which has been missed earlier. And if that comes out to be negative, then we can go for CT abdomen, because certain renal stones may be missed in small, particularly small renal stones may be missed in USG, and for that CT abdomen is the best test.
Okay. So I think sir has made a very...
Excuse me,
Yes,
can I
please.
come?
Yes, please come.
I think CT abdomen will be the best choice, because it's a 14-year-old child presented with a lumbar and back pain. That the chances that there is problem in maybe in the deep in the abdomen. So CT will be the best choice to see whether there is anything mischievous is going on. So that is the best choice as far as I think.
Sure, sir. Okay. Okay, please mute all the centers now. Amdekar sir will give his comments.
I think very well discussed by our friend there that there is a lumbar pain which is not same as a periumbilical pain, and therefore he is right that he can choose either an USG or a CT, and one of them said that CT is a better option. Yes, you are right, and I think that's what exactly was done, and it showed that a left ureter was a little dilated, and the diagnosis of retroperitoneal fibrosis was made. The point is, periumbilical pain is different than this localized pain. Why is that? Periumbilical is all right, functional, and the lumbar is not all right. Investigate. What is the difference? After all, both are abdominal pains, both are going on for a long time. What difference does it make? My leg is paining or hand is paining for last 4 months. No difference. Anyone thought, what is this difference between periumbilical pain and pain in a quadrant?
Anyone wants to answer that?
The lumbar
Rajesh
is
here.
localized pain. So it's a
Sorry?
localization. Periumbilical,
Okay.
any visceral involvement starts with periumbilical pain and then goes on to get it localized. But lumbar or back pain, it's already localized. So we need to look
Okay.
into, and the kidneys and the excretory system is of the retroperitoneal structures. So it's already localized. Because we expect.
Yes, ma'am. Yes, ma'am. Thank you. Thank you. It's already localized. Yeah.
Sir, the pain which is lumbar in origin, likely to be a retroperitoneal organ involvement, and that's why we need to investigate more.
Okay, please mute all the centers.
So periumbilical pain embryologically relates to some structures in the midgut. That's number one. And therefore, what are the midgut structures? The intestines. Second is peritoneum, and a third is the lymph node. Now, if it's an intestine, you have some intestinal symptoms, constipation, diarrhea, whatever. That's not there. Peritoneum, primary disorders are not known. And therefore, it has to be secondary to something. So that's also unlikely. And about the lymph node has to enlarge big enough for a capsule of the lymph node to stretch and cause a pain. And such a lymph node is palpable, even clinically. Therefore, that periumbilical pain, midgut origin embryologically, related to three structures, can be made out clinically. When you cannot make out, you need to worry about it. But just one small further point about this is an acute Appendicitis starts with periumbilical pain and 24 hours later shifts to right iliac fossa. Who shifts? The doctor shifts the pain, the appendix shifts, or our imagination shifts.
So what is the explanation behind this? Why does it start periumbilically and then move to right iliac fossa? Appendix is in the iliac fossa.
The initial part of the pain is related to the lumen of the appendix. And when it localizes in the RIF, it's more of a peritoneal involvement around the right iliac fossa area. So you get a localized pain in that. So that is the way it shifts actually.
Absolutely. Again, the same thing. Appendix is a part of embryologically midgut, and the pain is not peritoneal. Therefore, it's a dull pain. And then when the peritoneum gets involved, it is severe pain. That's a right iliac fossa. Just to make a point that periumbilical pain are often functional, but one which is acute could be next day shifting even to the some quadrant. So we'll keep that in mind.
Okay, now we move to the third case, and we will now focus on Hyderabad and Ranchi for interaction. Okay, and then of course local also. So this is a 18-month-old child who presented with developmental delay noticed around 1 year of age when he was not yet sitting. There were no other major complaints. So on detailed questioning, developmental quotient, gross motor is 45%, fine motor is 40%, language is 50%, and social is 60%. On examination, the growth and nutrition is normal, and there is spasticity in all 4 limbs. Do you need any more information? So, Ranchi, you want to come in? Do you want to ask any questions given this information?
We would like to know the birth history, asphyxia.
Yes, so this baby did not cry immediately at birth, needed neonatal resuscitation, and was given oxygen, etc. Yeah.
Motor developments during the first year.
So as we said, motor development, sitting was delayed. So sitting was not achieved till 1 year of age. And currently this 18-month-old child has a motor development of about 50%.
History of difficult delivery.
Yeah, so difficult delivery as in the baby did not cry immediately. So there is a perinatal event. What I'm trying to say is there's a perinatal event. Very good, sir. Hyderabad, do you want to come in? You want to ask anything? Hyderabad? Any other history you want to ask?
Any history of any previous illness like that associated with seizures? Like you suspect for any meningitis in the past or something, ear infections.
Very good. No such history. No such history.
Any documented hypoglycemia?
Very good. No documented hypoglycemia. Very good. Very good questioning. Yeah.
Rajesh, good evening.
Hello, sir. Sanjay, sir. Tell me.
Yeah. The interesting point in this particular case is that it is involving all the 4 domains. The motor, the fine motor, the language, and the social. So there's a gross developmental delay. It's not limited to motor. So we need to think of, are we dealing with something else other than cerebral palsy? That would be the way of thinking. It looks like, but we need to question ourselves why all the 4 domains are involved in this.
Okay. Okay. So locally, anybody wants to ask any other question beyond what has been discussed?
History of consanguinity?
History of consanguinity. Very good. Very
other
good.
Siblings.
Yeah, very good. No history of consanguinity, other siblings not affected. Okay, so maternal illness, no maternal illness. Very good. Sorry? No, any medication, maternal, no medications. Okay, now let's look at the options and let's start voting. So the options are MRI brain. In addition, tests for inborn errors of metabolism. In addition, genetic tests, or no tests and just counseling parents. And your voting time starts now. And all over the centers, please start voting. Okay, so the house is divided. Majority want imaging and a few want other tests as well. And there is a significant few you who feel that we should do nothing but just counsel parents. Okay, so now anyone can come in from Ranchi and take up any of the options which you think were right. Anyone wants to come in from Ranchi?
Sir, first, I would like to do MRI brain to anatomically localize the pathology. And if it comes to be negative, then we can think for other tests like for the inborn error of metabolism or genetic test, depending upon the MRI findings. Sir.
Okay, fine, we'll discuss that. Hyderabad, anybody wants to come in and defend or argue against any of the options?
Rajesh, the reason why we chose MRI brain was from the same question. Why there is 4-domain delay in development?
Yes. So Sanjay sir, can we, I know where you are coming from, but can we answer that doubt in our mind or try to answer it clinically? Your doubt is why all 4 domains are affected. Can we try to answer that clinically?
You are perfectly right, Rajesh, because the case doesn't come like multiple choice questions. You need to sit and then examine the child. Am I dealing with a dysmorphic child? Am I dealing with a child who has got repeated vomitings? Am I dealing with a family history of retardation? So obviously, cases don't come like multiple choice questions, though we don't have a way of teaching.
Sure, sir. Sure. Okay. So
I think the point to take is one, whether first thing is it a static disorder or a progressive disorder? Well, at the end of a year or year and a half, it may not be positively possible to differentiate the two because a very slowly progressive neurodegenerative disorder may fool us, like a cerebral palsy. That's number one. But the second is, was there a perinatal damage? We said yes. Okay. Inborn error of metabolism, the babies are born normally. And when they start feeding, depending on the degree of involvement, they would start presenting with symptomatology. If this child did not do that, then inborn error of metabolism is less likely. Okay. Next is a microcephaly is the characteristic feature of a cerebral palsy. And therefore, if this child had a microcephaly, so we could have asked whether the skull circumference was normal or not. And therefore, today we know that if you are suspecting on the basis of this a spastic cerebral palsy, I'm sure Sanjay did say that all 4 domains are involved, but Sanjay, you agree that all domains are also involved in spastic cerebral palsy, but the motor domains are predominantly involved as compared to social or adaptive. And therefore, if you had a typical story of a birth injury, perinatal injury, a microcephaly, and no such family history in the past, no consanguinity, then you are now considering a spastic cerebral palsy. And if that is so, then there is no need of even imaging. And the best of the neurologists have opined in the same way that the only reason spastic cerebral palsy should have a neuroimaging is if the birth history is normal, if the head circumference is normal, and if there is a past history in the family of a similar disorder, then of course we will have done a neuroimaging, even if we thought it was a cerebral palsy. So the point to make is, even the best of the neurologists consider cerebral palsy as not necessarily a indication for neuroimaging.
Meaning
And
you
I
don't
feel-
need evidence to call it cerebral palsy in terms of an MRI,
Yeah.
provided your clinical story is perfectly fitting in. So the indications of imaging are the ones where it may not be a a typical
And
story.
just to be in a lighter vein, there are only 3 indications of MRI brain today. Okay. One, MRI should be available, plenty. Every patient should have a brain, of course. And what's the third indication? Doctor should not use his brain.
Okay. And one more thing before sir, Vaidya sir, one sec. One more thing, please. Amdekar sir has always been teaching us, look at the growth, look at the growth, look at the growth, whatever is the case. Now here also, growth and nutrition normal rules out a metabolic disorder. So progressive or static and growth and nutrition normal. And then, of course, the perinatal insult and all. Yeah, Vaidya, sir. Yeah, of course. That history has to come in. Yeah. There are so many other histories that we want, right? Okay.
Sir, when we deal with children of this age, I mean, it's difficult to tell the parent that just based on my clinical judgment, this is spastic CP and this will stay like this for life. Whereas an MRI will be like a picture, an evidence that makes the parents more convinced about the fact that this child might, have this kind of thing for life. At the same time, I feel it also convinces them to go for regular therapy, which otherwise, if we just make a clinical diagnosis, they might not be very serious about it.
No, I fully agree with you. As earlier I said, we will give this opinion and say, but however, if you feel to confirm this, one could do an MRI. It is safe. Okay, much safer than CT scan, no radiation. The only issue is that sometimes, like all of us are clinicians, are never sure. Even the radiologists may not be sure. So they would say that on some area there is a doubtful thing. So you may have to repeat after 3 months or ask the clinician what to do. Now that becomes a problem. Okay, so we must counsel that. You are right, that we are nobody to decide not to do MRI, but we should decide MRI is unlikely to help, but you convince yourself that I am right after doing MRI. And once in a while, you may get a slap. They are right. So I think you are right that we can't be so sure about not doing anything. But
at least we can prevent the, the subsequent thing that such babies get repeated imaging. After 6 months and 1 year, someone new arrives on the scene and says, "Chara वापिस करके देखते हैं कितना improvement हुआ." Now that is a crime, absolutely, right? Okay. So let's move on to the next case, and we will now focus on Delhi and Patna to interact with us besides others. So Delhi and Patna can be spotlighted, and we move on to case 4. So a 14-year-old healthy child presented with a sudden onset of what looked like a fainting episode with transient loss of consciousness and quick recovery at the end of a strenuous game. On examination, no abnormal findings. Do you need any more information? So, Patna, can you come in? You want to ask any questions based on this case vignette? Delhi, do you want to ask any questions? Any more details?
Any past history of similar complaints?
No, sir, no past history.
Any history suggestive of exercise intolerance in the past or to suggest a cardiac cause?
No, sir. Good history, no, sir.
Any associated, sweating or...
So when this child or this adolescent fainted, yeah, he did sweat after that.
Yeah. Then the possibility of vasovagal can be considered.
Okay, fine. Patna, any more questions you want to ask?
Any history of cardiac abnormality or any disease? We will
No such history. Okay, thank you. Locally, anyone wants to ask any more questions? History of palpitations? No. He had taken his breakfast, yes. He had taken his breakfast. Incontinence of urine stool? No. Family history of fainting? or epilepsy. Okay, so no family history of epilepsy, no family history of fainting. Any history of sudden death in the family? No.
That's about
No, this is the first episode. So any cardiac history in the family? No. Very good. So a lot of very good questioning. Now let's look at the options. No tests, counseling the parents, echocardiogram and ECG, Holter monitoring, EEG and MRI brain. And your voting time starts now. So all over the centers, please scan the code and start voting. Okay, anyone from Delhi wants to come in and give his or her analysis of the situation and justification of the option? Anyone from Delhi?
The point here is that it was the first episode and there was very quick recovery at the end of the loss of consciousness. So that makes us think that probably it's functional. And whether was she a female or a male?
Oh, boy.
Boy here. Functional seems at this age seems to be more common in females though. However, so it looks more like functional, but as a clinician, I would definitely like to do an ECG and rule out prolonged QT syndrome.
Okay. Locally, anybody wants to comment on? Yeah.
There is a very important history of fainting after the end of a strenuous exercise. So some cardiac issues like outlet obstructions can lead to fainting, especially after a strenuous exercise. So we can't call it a functional. At least an ECG and an echocardiogram is necessary.
Okay. Any other inputs? Yeah.
Why not EEG?
Why not? Okay, yeah. We will discuss that.
I think anything happens during exercise or immediately after exercise is a worrying factor. A typical vasovagal attack, yes, that's the most common cause of fainting. However, that comes only with a small trigger, maybe a starvation. Typically in the morning, assembly at the school, you're standing there, you're not well hydrated, you're not had anything. Such triggers suddenly fall down and come back again. But if it's related to exercise, now all that the history says is at the end of the strenuous game, we don't know whether it was immediate or it was after some time. And therefore, one is a little worried about it. And what is the worry? Not neurological, not the seizure disorder. So EG and etc. are all out. But it could be some rhythm disturbance, and one of the common rhythm disturbance which can be easily overlooked even by ECG or or echocardiogram is a long QT. And therefore, that long QT might need that. Any comment, Dr. Parekh? And therefore, one might like not to miss long QT. And if that is so, then the Holter may be a better idea. But if you're sure that no, not immediately after strenuous game, but thereafter we were resting, we had some water to drink, and thereafter it happened, you might be on the borderline of considering a rhythm disturbance vis-a-vis a vasovagal attack. Don't take a chance on this. It could be dangerous. And therefore, I think ideally it will be a Holter monitoring. But you say that more likely one over the other. But when one is more serious and the other is so benign, you would rather tip in favor of a serious thing to rule out. Even if the evidence is negative, it's worth it.
Having said that, just to add a little, so there is a difference between the syncopal attack happening at pull flight, as the words say. So in the middle of active exercise versus at the end of exercise, as in the cool down phase. So in the cool down phase, it could still be vasovagal. And therefore, that's a subtle difference that, as sir said, we'll have to get into a lot of details in the history. Secondly, vasovagal often has a prodrome, whereas a cardiac does not have a prodrome. So it's like a sudden, like the switch of a button. So that history also we will have to try and get. These are, of course, the differences. But the point is, what is the evidence to prove a vasovagal syncope? Suppose you have diagnosed somebody as a vasovagal. What is the evidence? How will you prove it? So past history, though, it can have past history of cardiac syncope also, no? That is not a evidence that this is vasovagal.
Table tilt test.
So will we do a table tilt test for everybody to prove a vasovagal syncope? That's the question. Yeah, so history of trigger is there. So do we need to prove, or that's good enough? Means what I'm trying to say is, I'm just trying to reinforce that there is no black and white test to prove vasovagal. Incidentally, table tilt test also is not a good idea. Even if you are thinking of vasovagal, it has its plus and minus. Interpretation is very complicated, and you can't at the end of the say that I am sure this is vasovagal. Okay, we move on to case 5, and we will have Indore and Varanasi interact with us. So Indore and Varanasi can come in, and let's discuss case 5. So 1-year-old child presented with regression of milestones for the last 2 months, noticed after recovery from an illness. The illness was high fever for 3 days, followed 3 days later by a generalized seizure and then unconsciousness. So the child was admitted somewhere. He was in hospital for a month. Various investigations were done. Finally, he was discharged on anti-TB therapy. Now, today, at 3 months from the illness, this child has a large head, upper motor neuron hemiparesis, and global delay in terms of milestones. The question is, what are the options to prove the diagnosis? And the options are CBC, ESR, CSF routine, and adenosine deaminase on CSF. In addition, MAN2 and or IGRA, CSF routine culture, gene expert, and CT scan of the brain. And fourth, CT scan with BAL for culture and gene expert and family screening. So all over the centers, please scan your code and start voting.
All of them. इसमें CSF नहीं है डी वाले में.
That's not the answer which is correct. Majority is not always correct.
Okay. Now, someone from Indore can come in. And it would be nice if you can first tell us what is your clinical analysis. And then if you are also either option C or option D, you tell us how that option will help us.
I'm from Indore. From clinical analysis, most likely we are dealing with the complication of the meningitis. Most likely tubercular meningitis, what has been shown. Or if we are not considering tubercular meningitis, then secondary to bacterial meningitis, this kind of complication may happen. So to prove the complication, like most likely is the developing hydrocephalus or subdural effusion. So to confirm the diagnosis, definitely CT scan of brain is required. CSF routine culture and gene expert, it may be negative, it may be positive. It's ideally the CT brain because he's already on anti-tubercular drug. So,
And sir, it is 3 months down the line.
yeah. So, CSF routine culture and gene expert, if positive, it will add in the further management. But if negative, it will not rule out the cause like tubercular. You have to continue AKT even if it is negative.
Okay, thank you. Varanasi, any additional points you want to make besides what sir has said from Indore? Okay, we'll come back to you all in a while. From here, anybody wants to add anything or differ or change? Okay, sir.
I think the diagnosis is TB. Down the line, 3 months, this is an effect of that TBM. The question is, are you likely also to face a drug-resistant TB? A typical drug-resistant TB, MDR TB, can show improvement in the first 2-3 months and thereafter get even worse because some drugs are working, not all drugs are working. So partially, the drug-sensitive bacteria are getting less and less in population, but the drug-resistant population is increasing, and you will end up with a further worsening. I want to be sure that I'm not facing that kind of a situation today, for which I certainly need some bacteriological or molecular diagnosis more than a CT scan. CT scan will not tell me whether I have a drug-resistant TB or not, but the molecular test and also a CSF culture, because one of the tests may be negative, the other may be positive, and therefore ideally you do both and confirm that it's a drug sensitive TB and then go ahead. CT is not my first choice at all. It will tell me structural, yes, it is TBM. So I think I would go for that confirmation only because drug resistant TB is not uncommon and a partial improvement is a rule. And therefore, I think that would be the ideal thing.
So again, the point in this, sorry.
The patient is showing some kind of problems. See, the problem is already there. The head is enlarging. So you have to prove that there is any structural problem there, because you have to address that also, and that may be the reason, not necessarily because if the patient is having a further deterioration in form of fever and ongoing problem with the TB meningitis, then yes, you are more likely to go for the bacterial test and prove that this is a MDR. I mean, in my
No, so there are two issues here. The first issue is we are discussing evidence versus experience. So the first issue is that at this stage, at 3 months down the line, when this child was originally admitted, there was no proof of TB. Means they couldn't prove TB. They didn't get any TB bacteriology positive. They couldn't show at least. And therefore, the question today, first question is it TBM? And if so, what is the proof? The answer to that question is by experience, this is TBM. Because you add all the circumstantial evidence and you call it TBM. Large head, global encephalopathy, focal deficits, hydrocephalus, all that. So that is one part. That you'll have to continue. Anti-TB is a given. You'll have to continue. Now the second question is, should you even attempt these tests today because it is 3 months down the line? That's where what sir is saying is that you attempt just to be 100% sure, because today if you still get it, that means you are resistant because it's 3 months down the line and you are still having bacteriological positive. So he's going to be resistant. So that's the message.
I think,
Sir, getting, hello? Can you hear
Yes.
me?
Yes.
Sir, getting the positive test at 3 months, like for example, if you are doing gene expert, that doesn't mean that the disease is active. It could be dead bacilli. So that doesn't
Sir,
mean that.
Yes, sir. Rawat sir, Ramdekar sir said culture. He said culture also. Yeah, not gene expert alone. Agreed, sir.
My doubt is that because this child has not shown deterioration in these 3 months, what would the CSF? I mean, why are we expecting to even do the CSF at this point? Because large head hemiparesis and global delay could have been because of the insult of TB and encephalitis 3 months back when he had the history. There is nothing that suggests in history that in these 3 months also he has worsened per se. So I don't know whether, I mean, these options.
Has he improved? Okay.
Jagruti, what you said is right, but 3 months is a time when a drug-resistant TB will show false improvement, because out of 4 drugs, even if 2 or 3 are working, but 1 or 2 are not working, then that population will start slowly multiplying after few months. And then we have certainly seen a child deteriorating after 3, 4, 5 months of an initial improvement, and everybody is happy. The child is home. Well, some damage, but we'll take care of that damage. And then suddenly goes, and once it goes down, then there is no retrieval. And that's why just a point that here is the need for evidence, because the experience might be, if wrong, occasionally will be really a fatal outcome. So whenever the outcome is fatal, you go for an evidence, not only by experience.
Tokani sir, the child would present with failure of like a child with DRTB will have. Hello.
Yes, Rawat sir.
Sir, the child with DRTB will have failure to improve. This child is having complications of TBM. He is having hydrocephalus, which is complication. It doesn't indicate that he is having DRTB. DRTB means the child is not improving. Like for example, he is having continuous downhill course, or the child is having continuous seizure, fever. Then we'll think of DRTB. This child is having a complication of a disease which has been treated probably appropriately. So probably he needs some surgical treatment other than thinking of DRTB.
So Rawat sir, we are not saying that we are thinking of DRTB in this child. What we are saying is, we have a situation where TB ka diagnosis has not been proved in black and white. Will we do tests today or no? That is the issue we are discussing.
Yes, sir.
Evidence versus experience.
We'll do the test to confirm, because microbiological confirmation is very important. So we'll definitely do a BAL, and there is no doubt about it. We'll do it.
Correct.
But
So
we'll
we are
not think of
discussing that, and DRTB is an offshoot of that. It's an offshoot. We are not upfront saying that this is DRTB.
I wanted to say this, that when they started TB, they should have had done CSF, culture, gene expert, which we have been doing last 10 years.
Correct. So you are right. So ideally, so the message is everyone, anywhere and everywhere should be doing all that. So some of us are not doing, we are faulting, we need to correct ourselves. And the second is, there are situations in real life scenarios where in spite of doing, you may not be able to pick up. And then you are stuck, because then you have to again fall back on lack of evidence, but clinical diagnosis.
And I think that today, sure, malaria, typhoid, everything has to be evidence-based, definite, guaranteed investigation. But many times we say our culture is not a good culture. So negative test doesn't rule out a good parasites to be seen. You have to see conscientiously. Where is the conscientiousness? And therefore we finally say negative test is also positive, and positive is of course positive. So many of us may not do it. You are right. That absolutely, absolutely, you are right. No question.
Sir, in this case, is it better to go for CSF culture at this level or BAL culture?
CSF or BAL at this stage at 3 months?
I think to begin with CSF, my worry is drug resistant, and it has to be there in the CSF. Okay, I may not go. Now, if you find that CSF is absolutely normal, but you are worried whether it is still drug resistant, I'm not worried, because how can a drug resistance be in the lungs, but a drug sensitive in the CSF? That's unlikely. So my focus is on the CSF.
Sure. So we'll move on to the next case now, and we will ask Chennai and Gaya to come in again. So Chennai and Gaya, And we move on to case 6. So a 4-year-old presented with difficulty in walking, irritability and fever off and on for the last 2 months. On examination, there is proximal muscle weakness and a skin rash, and a clinical diagnosis of juvenile dermatomyositis is suspected or made. Now, the question is, we are talking of evidence versus experience. So the question is options to prove the diagnosis. First option, CBC-ESR muscle enzymes. Second, in addition, EMG. Third, in addition, muscle biopsy. And fourth, in addition, MRI. And your voting time starts now. So all over, please scan the code and vote. Okay, so can someone from Chennai come in and give us your take on any of the options, why you feel it is right or not right? Anyone wishes to speak from Chennai? Okay, anyone? Yeah.
Myositis is clinical diagnosis. We should have a supporting evidence for which we need to do a basic investigation, these muscle enzymes, and proceed further.
Okay, sir. Anyone from Gaya wants to speak anything? You want to add something? You want to say something different? Okay. We'll come back to y'all. Locally, anyone wants to say anything? How do we prove the diagnosis of juvenile dermatomyositis? Okay.
I think in rheumatology, the problem is how to select the correct antibody, which antibody is likely to be giving you an answer. And more than that, also the tests possibly tell you which are the best drugs to suppress the immune response. And therefore, generally, the rheumatologist would tell us that a selection of anti-inflammatory drug and also a chances of some complications occurring in other organs is an important issue, and therefore a test possibly give you a chance occurrence. Like, for example, you have a juvenile idiopathic arthritis. You would certainly look at the eye. If you have an SLE, you will certainly look at the kidney, even if the kidney is normal, because the choice of drugs, the ultimate outcome varies a lot. Therefore, rheumatologists tell us now that do every test possible. Some of them might give you an idea which is the risk factor for any particular complication, and it will also give you an idea which could be the best anti-inflammatory. Today we have a lot many anti-inflammatory drugs, including biologicals, and therefore I think the ideal situation is ask the specialist to opine, and most of them will do all kinds of tests. We would wonder as a generalist, why so many tests? Rightly, somebody said it's a clinical diagnosis. But today we know, like the cancer, more the tests you do, you can choose the right combination of a chemotherapy. And I think that's very important today. So the test may not add on to a diagnosis, but test may guide you which drug to ask, which complications to anticipate. And I think today's modern era has gone beyond an evidence of diagnosis, but also an evidence of likely outcome, likely complication, likely therapy, and so on and so forth. So the idea is as many tests as possible to give this answer. Better, of course, for all of us to leave it to the specialists. But as a generalist, I must know, because my patient will come and say, sir, they're asking too many tests. You need to know, yes, they are right, that they have to ask for so many tests.
And having said that, as sir said from Chennai, the diagnosis is clinical. So none of these tests will prove the diagnosis. What they can prove is a inflammatory myopathy, that's all. And whether it is juvenile dermatomyositis, it will just be a combination of all that with a few positive antibodies. The MRI is also a different type of MRI. It is called STIR MRI, which will show muscle edema. So there are occasional cases where you don't have all the features. So then you start looking for all this to give you added evidence. Okay. So we move on to the next case and we will ask Gorakhpur and Ranchi to come in again. A 3-year-old healthy child presented with the first episode of wheezing and cough and was rushed to the emergency department. Nebulized and he felt comfortable. There were no obvious trigger factors noticed. There's no personal or family history of atopy. Options, next steps, CBC, CRP, IgE. Second, pulmonary function tests including PEFR, skin prick tests and specific antibody tests, or counsel about steroid rescue dose for further episodes. So your voting time starts now. Please scan the code and start voting.
Counsel about steroid rescue dose in the previous episodes, first episode.
Okay. So from Gorakhpur, can you come in? What is your option, choice of option? We can't hear you actually, sorry. No, we can't hear you. Okay, we'll come back to you in a minute. Ranchi, can you come in? What is your choice of option? Gorakhpur, sorry, we can't hear you.
Sort of thing, because it is sudden presentation and being nebulized, and we have to counsel not going for the lot of tests.
Okay, so you have chosen to counsel about steroid rescue dose.
Yes, sir.
Okay, okay. Locally?
Suggestive of aspiration or a foreign body. One
Okay.
body to be same foreign body first diagnosis.
So
Chest will help here instead of steroid. No.
He was nebulized and he felt better. Which foreign body? We have a pulmonologist here. Okay. Final opinion. Yes. Tell us as journalists what.
Thank you, sir. So, since it was a first episode, I would rather be conservative in over-diagnosing it. Had there been a past history of personal or family history, then again, the first basic test, see, pulmonary function test PEFR is not possible for a 3-year-old child, so that's out. Skin prick test, again, I don't want to find a specific trigger as of now. Steroid rescue dose, if this child is getting better just on bronchodilator, whether to continue on a controller steroid for a longer time, I would still be a bit conservative about that. If it's a first viral triggered wheeze or a multi-trigger wheeze, as in there is any environmental trigger wheeze, that needs to be found out. Again, history plays an important role. So I would still not even do none of the above, and I will wait for, if at all there is a second episode, then I would rather just do an IG just to find whether it is IG mediated or non-IG mediated, and that would be helpful for counseling the parents. That's it.
And
good. But just one more question. Suppose there was a family history. Now, would your thinking change a little?
Yes. So as we have this modified asthma predictive index, if he fits into all these major and minor criteria, in which family history is one of the major criteria, then I would likely think towards more of an atopic kind of a cough rather than going into all different variants.
And tell us about the place of all those allergen tests. IG is useless, I suppose. Yes, but what is useful?
Again, so IG, so in a certain way, non-IG mediated has different, in a way of treating IG yes or IG no, whether high IGs or even normal IGs, that helps in differentiating. Allergy test, if they are resistant to your, or they're having recurrent episodes, then you need to pinpoint what is the common cause. And most of these reagents are most commonly available, are there present in your environmental place itself, like your most common house dust mite. The most common allergen, if taught, I mean, if educated properly, that could work wonders rather than giving recurrent courses of medications.
If somebody wanted to say something here.
I wanted to ask Dr. Mohite what you meant. Can you just elaborate on the IgE test? Because from a prognostication as well as from the treatment perspective, how would that change?
Right. So as we most likely know, A2 mediated allergies are only Th2 mediated, and that those are the ones in which Ig relatively could go up, but there could be normal Ig related allergies as well. So those are the tests in which probably your rescue steroids, your regular bronchodilator steroids might not work, and to go towards immunomodulation, you have to go towards an immunotherapy. So IgE, as sir rightly said, practically of no use considering a child who's coming with recurrent wheezing, because even a high IG or a normal IG is not going to make any difference in your treatment line of management at that point of time. But probably for prognosticating or for telling the parents, counseling the parents of the recurrence of the events, yes, it will help a lot.
So actually, what you're saying is perfect, Kaustubh, but the practical problem is people tend to use IgE to make a diagnosis, one, and to grade the severity of the diagnosis, another, both of which are extremely erroneous.
Yes, sir. Agreed, sir.
Same is about eosinophils.
What is this steroid rescue dose means what?
Steroid rescue dose means when a child is brought to the emergency department with an acute severe episode of wheezing, you can counsel them that next time this starts, they can give a dose of steroid at home, oral steroid, so that it starts working, or you buy time so that when you get on to bronchodilators, etc., they will, steroid makes them work better, etc. So even in our ICUs, in our emergency departments, in acute severe asthma, we do use steroids. So rescue dose is something like that, which you counsel them to take at home, having already had one bad episode and brought to the emergency department. Okay. We move on to case 8, and we will now take Patna and Indore again. Patna and Indore. Okay. So 12-year-old presented with episodes of severe headache lasting for 10 to 12 hours, self-limiting, but recurring every 4 to 6 weeks. No family history of migraine, and physical examination normal. So our options are check for refractive error, neuroimaging, CT scan of sinuses, or counseling without tests. And everyone from all the centers, please scan the code and start voting, and so also locally. Rawat sir, you are our designated expert. So please allow somebody else to speak.
Hello.
Yeah, someone from Indore come in. Yes, sir. No, sir, we are not able to hear.
The first clinical impression is this could be a tension headache.
So the counseling without test, I think, is good enough. A refractory error will be a constant one. It will not come and go like this. Neuroimaging, if raised ICT is there, which will disturb the sleep and all. So, I mean, the neuroimaging or CT is also less likely to help. So, the most likely diagnosis is the fourth one.
So, sir, in this scenario, can I be sure that there is no raised ICP coming up?
Yeah,
How
raised
can I be
ICT,
sure?
raised ICT will might disturb the sleep. It will be more in the morning, and the vomiting would be there. The child would be very irritable, and it will be a constant feature. There will not be a gap.
Okay, fine. Thank you, sir. Patna, anybody wants to come in with any?
Actually, we would like to do neuroimaging because this episode is recurring every 4 to 6 weeks. And there is no history of migraine or any other such disease. So we should go for it so that any treatment can be given to the child or not. Blood pressure should be checked, I think.
Okay.
And
Okay, ma'am. Okay.
Sir, I would like to.
Yeah.
Sir, I would like to have more history.
Yeah, Indore, please come in. Yeah.
Sir, I would like to have more history because it's appearing every 4 to 6 weeks. So it could be cyclical headache like pattern. If this is a male child or a female child, 12-year-old. If female child, it could be cataminal headache associated with the menstruation cycle. Cataminal headache and cataminal putting or premenstrual tension could be the differential if this is a female child.
Okay, so you'd like to take more history and then decide. Very good. Okay. Locally, any inputs? Anybody wants to ask anything? Anybody wants to? Yeah, once.
First of all, the duration, the 4 to 6 weeks, and it's lasting for 10 to 12 hours. So if it is some neurological issue or pathological, patient should have been deteriorated by now. Secondly, any CNS symptoms, as already mentioned, headache, headache is there, but not on a continuous basis. Any vomiting, sleep disturbances, or academic performances or behavioral changes, etc., is not there. Regarding the CT scan of sinuses, no symptoms are there for this. Regarding the refractive errors are usually not a cause of headache. If at all, some minor it may be. So D is a good option.
I think if you look at the pain in general, most of the pains are inflammatory. This is obviously not inflammatory because it doesn't come up suddenly and doesn't disappear suddenly and doesn't recur. Next is whether it's a vascular pain. Third is whether it's a neurogenic pain. Fourth is whether it's a referred pain. And the fifth is whether it's psychogenic pain. Psychogenic is out. Referred is also out. Because the referred is typically depending on the neural segments, like a myocardial infarct with a shoulder, whatever. So two are out. Inflammation is out. Therefore, finally, it's a vascular pain. What is the peculiarity of vascular pain? Sudden appearance, sudden disappearance, and recurrence in the same fashion. So this is a vascular pain. What is vascular pain? Recurrent vascular. That is like a migraine. It's a vascular pain. You get further history. It starts slowly. By another hour or two, it gets worse. At the peak of it, you can't even see the light or hear the sound. It disturbs you a lot. Thereafter, you may even vomit. Thereafter, you may get well. In between, you're absolutely all right. It becomes a clinical diagnosis. And therefore, if it was a vascular pain out of any other vasculitis, it would not have suddenly disappeared. It would not have suddenly recurred again. Therefore, migraine can come with even a hemiparesis, which recovers suddenly. But make sure it's a vascular pain. Make sure it's not a persistent vascular pain. It's a recurrent vascular pain. So barring the possibility of some inborn error of metabolism like a mitochondrial, for example, the malas who come like that, but they have many neurological symptoms and signs This is non-localized. Therefore, we will take it as migraine till proved otherwise. One thing is again sure, there is no emergency to investigate. We wait and confirm over similar episodes occurring in between they are normal. So I don't think we need to do anything except counseling without test for a while, right? Refractive error is never the cause of headache. Okay. The refractive error, the patient feels discomfort retroorbitally, and therefore some of them may say, I have a little headache. Okay. You check the refractive error, put on the glasses, the headache will continue. Refractive error is not the cause of headache.
And in fact, even sinusitis is largely a clinical diagnosis. In the olden days, we used to do X-ray, Waters view. We have given that up and moved on to CT scans. But even 50% of the time, CT scan may show something in the sinuses when it is not sinusitis. So it is a largely a clinical diagnosis. And fine, yeah. So we'll move on to the next case.
You might know that sinusitis is so common with many one of us, isn't it? What happens if my CT shows that?
So again, in most of the kids who usually suspect, like I'll just give you an example, suspected case of primary serial dyskinesia in which there is dysmotility syndrome. So in these cases, lung problems come with most of your upper airway problems, and most of these kids, even without any upper airway obstruction, have some mucosal thickening, have some sinusitis. So having that or not having that is not going to make much of a difference in terms of clinical point of view. But as sir rightly said, it's a clinical diagnosis. So we should rely more on your clinical history and examination rather than on your CT scans.
Okay, we move on to the next case, and now Kolkata and Hyderabad can come in again. Hyderabad and Kolkata. Okay. A 18-month-old child presented with high fever and crying for 3 days. On examination, growth normal, stable, irritable, but no localization, otoscopy normal. The options are, so high fever and crying, irritable, but no localization. Options are CBC, CRP, urine analysis, decision after test results. Second is hospitalize CSF and then manage as per reports. Third is start IV ceftriaxone in addition. And fourth is, in addition, start antiviral and antimalarial. And your time to vote starts now. So all of you, please start voting. Okay, so someone from Kolkata wants to come in and discuss what is your choice of an option.
Hello, sir.
Yes, sir, please come in.
As the child is high fever, so it is either infection or inflammation is present. Number two, the child is crying. So as the child is crying, either the child may have pain or may have respiratory distress. These are the two common causes of so little child is crying. And there is no localization. An infection without localization, there are two common causes. One is urinary tract infection, another is enteric fever. In this short history, we cannot come to the enteric fever. So we'll first search for the infection, either urine or there is a bacterial infection or like that. So I suggest the option one.
Okay, thank you so much, sir. Anybody from Hyderabad wants to add anything? You want to ask any more details about the story? Any other questions?
Rajesh, the story which is given is quite inadequate because it just says high fever, crying for 3 days. Now, what does it mean? 18 months old child crying for 3 days is something which is not very usual. If I see a 3 months old child or a 6 months old child, then I'll scratch my head and say, because that's the only way of expression. Now, growth is normal. Child appears to be stable. So at least there's no critical illness. Child is irritable. There's no localization. Means I'm not able to see the focus. So with this, I would go back to the history and try to find out whether he has got some injury, some abscess, some painful situation somewhere, which is the cause. That's number one. But as far as the options are concerned, because we are living in an age of ABCD, I would consider A as the first thing because that will give me a lead to find out whether it's infective or not.
Okay, sir. Okay. Locally, you want to ask any more details of the question? Sanjay sir made a point that this is inadequate. So what do you want to know? About irritability, I'll clarify the child is crying all the time, is irritable all the time. So it is not just at the peak of fever, he is crying even between the fevers.
Any history of photophobia, sir?
There is no poor feeding, there is no vomiting.
Photophobia, sir. History of
There no
photophobia.
crying associated with urination, no photophobia, no red eye. Altered behavior is irritability.
Neck stiffness, sir. History of neck stiffness.
So this is more like a inconsolable crying, and I think the child has enough red flags to warrant an admission, is what I think. So maybe the option 2 with hospitalized. There is high fever, child is irritable and crying for 3 days, and as you mentioned, is even crying in between the febrile episodes. So this is definitely a red flag, which I would consider hospitalization.
Limb movements are fine. So there's no increased crying with the limb movements. So now the question is, what do you think this is? Is it a bacterial infection or a viral infection? Start thinking. Bacterial? Okay, where?
Maybe osteoma.
Where? Possibilities. Urine. Okay. Okay, re-examine CNS. 18-month-old CNS infection, high fever for 3 days, irritability, no vomiting, no seizures, no refusal to feed. Still CNS? Okay. What about urine? Okay, urine is possible. Okay. Any other places? Can it be a viral infection?
Some of the, in dengue also.
So he shouldn't be irritable all the time. Can it be non-infective?
Kawasaki, like they present with high fever, crying. You have to wait and watch and see.
Sir, he's saying it could be Kawasaki.
I think give him a clap. Give him a clap. Okay. I think the point is 3 days of fever and crying, but it is still not worsening. 18-month-old child with any infection, first is urinary infection is out. It's a pyelonephritis which causes high fever and it does not cause so much of irritability. The irritability while passing urine is a lower urinary tract infection where there is no high fever. Pyelonephritis doesn't come with so severe pain. No. To that extent, urinary infection is out. Second is TNS infection. Again, 18-month-old should have got into a seizure, unconsciousness, whatever. So 3 days of story, but not worsening nor improving, suggests a non-infective inflammation. And that is the inflammation which is hiding, and therefore typically maybe a meningeal inflammation, as in Kawasaki. And therefore, don't forget that when 3 to 4 days, 5 days, the typical story is 5 days. But today we should start suspecting Kawasaki even at the end of 3 days. And the way to do is non-progressive, non-improving, non-localizing, severe irritability is the feature of a Kawasaki. And I think you made a very good point and excellent. Thanks. Rajesh, we have one more case.
Yes, sir. Okay, so we move on to case 10 and we can have Delhi and Varanasi come in. And Gorakhpur also, because that time their sound we couldn't hear. So Gorakhpur can also come in. So Delhi, Varanasi, Gorakhpur. A 10-year-old healthy child presented with high fever for 2 days. Amoxiclav was started on day 2 itself. The child was afebrile the next day and one more day. He remained afebrile. Then high fever recurred on day 5. And now there is a left thigh swelling and pain. The amoxiclav obviously is on from day 2. On examination, there are local signs of inflammation. So this was considered osteomyelitis. There was high count, high poly. MRI said that it looks like osteomyelitis. So antibiotics were changed, upgraded, but it all failed. And another 15 days passed and the child remained the same. Options are repeat CBC before taking any further decision. In addition, blood culture. In addition, bone biopsy, including culture. And withdraw antibiotics for 3-4 days and observe. So everyone please scan your code and vote. Okay, Gorakhpur, you want to come in and you want to tell us what is your choice? Nahi sun raha again. Mike, we are not able to hear.
Hello.
Yeah, now we can hear. Yeah.
Basically, we go for the third option because this child is even after getting sufficient dose of an amoxiclav is not recovering and MRI showing osteomyelitis. So we should have a bone biopsy to detect whether this organism is resistant to our antibiotics. Even we can get another opinion about this child is having high TLC. So, and we don't have GBP about blast cells, etc. So we should consider about the possibility of malignancy also.
Okay. Varanasi, you want to come in? Any additional comments? Any different comments?
Sir, in this case, initial antibiotic of choice is not good. I think there should be, if make the diagnosis of osteomyelitis, there should be IV infusion of the antibiotics first. And if you start antibiotic and not responding, then we should change according to the culture. So blood culture is must in this case. After the culture we are getting, then we can start another treatment.
Okay, sir. Delhi, you want to come in? Any different comments? Any thoughts? Any analysis of the clinical story? Our session is evidence versus experience. So the question that all of us have to ask ourselves is, what is the evidence which will clinch a diagnosis of osteomyelitis, bacterial osteomyelitis?
Dr. Chokhani.
Yes,
I have
sir.
suggestions are here from Ranchi.
Yes, sir.
Child recurred again with the fever while always on amoxiclav. Responded again the fever recurred. Seems to be a case of enteric fever. I would like to go with the blood culture then.
Okay. Fine. Locally, any comments, any thoughts? Yeah, 1 minute, sir.
Child, sir, Gaya wants to reply, sir.
Sorry?
Gaya wants to reply.
Okay,
Gaya.
we'll come to Gaya. Yeah, we'll come to Gaya. 1 minute. Locally, anybody?
I must say that day 2 have started antibiotic, which is wrong. So I would like to wait and watch and let the case evolve, and then we'll be able to come to diagnosis.
Okay, Gaya, come in. Gaya.
In day 2, he has started antibiotic amoxiclav, and the child become afebrile. And if the child responded to the antibiotic, the fever will not come again. But here the fever recurred. So the antibiotic is not working. But the fever, disappearance of fever suggests there is no osteomyelitis like bacterial osteomyelitis. It is inflammation, but there is no bacterial osteomyelitis. It's something else.
Okay. Very important point made. Okay.
I think in clinical practice, we often hear but don't listen. We often see but don't observe. And we often know but we don't think. This is applicable to all of you here. Read the first line of the history. The fever disappeared in 2 days. Which osteomyelitis, the fever disappears in 2 days. And therefore, this is not an infection at all. One of them said, this could be non-infective inflammation. Yes, it is totally a non-infective inflammatory osteomyelitis. It is known to be recurring. But you see the first sentence? 2 days later, he got better after a day or two of being febrile. Which osteomyelitis infective does that? This is an example of how we could see, but we did not observe. And what's the difference between listening and hearing or observing and seeing? When we listen, the sounds go to auditory cortex, go to frontal cortex to say, what does it mean? Same thing about the seeing and observing. When we don't use the interpretation of what we are hearing or so, this is one example. These are real stories. And the history, if you hear properly, you would have known in the first sentence that this is not an infection at all. This child had a bone biopsy, hematologist had seen, surgeons had seen, multiple tests were done. And what was the clinching point? Not only correctly analyzing it, but the child was stable throughout all this period. When there was no fever, he would eat well and be happy. Which osteomyelitis is this? This is one example how we know but we don't think, right? I think it's 7 o'clock. Yeah.
Tea is not ready, so we've got time for one more
But
case.
he will be next morning.
So we have enough cases and they have enough stamina.
Okay.
So even if tea is ready next morning, it's fine. Okay, so we move on to the next case and we can have Bangalore come in along with Chennai. And yeah, Bangalore and Chennai, or you can put everyone actually for this last one. Okay, Lucknow, you wanted to ask something, I believe. Lucknow?
Actually, Lucknow wanted to make the diagnosis of reactive arthritis from the very beginning for obvious reasons, as Dr. Amdekar has already elaborated.
Okay, okay, sir. Okay. A 3-month-old healthy infant on exclusive breastfeeding developed mild fever and cold for a day. Mother also has fever and cold. On examination, no findings. Options: paracetamol, SOS and observe. In addition, CBC, PS, CRP, urine. In addition, mother's rapid antigen test for influenza and NS1, or hospitalize, send for tests and start IV ceftriaxone. You can start voting now.
Well, I think majority of you are voting for the first option. So would any one of those people who are joining us?
Bangalore or Chennai can come in. Bangalore, you want to say anything on this case?
Hello. So mild fever does not need paracetamol.
From Chennai? Or anyone else? Anyone else?
Sir, mild fever will not need paracetamol. We just need to observe.
Okay. Chennai, anybody wants to come in? Any center, raise hand if you want to speak something.
Is supposed to be a normal child, infant, on the breastfeeding, so there's nothing to be done. It's only fever to be subsided, but paracetamol will be enough.
Okay, sir. Locally, any comments? Yeah, one sec.
So from Chennai, one query, sir. Just give paracetamol in order to reduce the anxiety of the mother.
Yeah, in this case, I just want to say, but she should continue.
Upar aise.
She should continue to breastfeed. Most of the time, when the mother has a fever, usually they stop breastfeeding. So here, that's it. Paracetamol is SOS, but she should continue to breastfeed.
Sir, hello.
I like to highlight one point.
Yeah.
When you talk of mild fever, what do you mean by mild fever? We should quantify it. If the fever is less than 100.5, baby doesn't require any treatment. Most of the mothers, they just touch the forehead and say, "बच्चे को बुखार है." That doesn't mean anything. So wait and watch. If the fever is more than 100.5, then only paracetamol.
Sir, you're right, absolutely. But I would just like to add that the number also is not sacrosanct. So we could have a newborn with 100 fever, not even 100.5, and the newborn could be in sepsis. So the number is not sacrosanct. We have to look
Healthy
at the
child.
Yeah.
In an active, healthy child breastfeeding.
Yes, sir. Yes, sir.
Moreover, in places like Lucknow, particularly in this weather, the temperature of the atmosphere is also very high, and very often they overclothe the baby. And mother, since she is having mild fever and cold, it is likely to be a viral illness. So,
Sure,
and the
sure.
child is active. So we
Yes,
don't
sir. Yes,
expect
sir.
anything significant.
Yes, sir. Yes, sir.
Purely a viral.
We'll stop here this case and we'll move on to the next one.
I think what you said is absolutely right. More than fever or no fever, at that age, what is the behavior of this child? Is he ready to breastfeed? Is he sucking well? Is he getting happy after a feed? If that is so, then irrespective of 100 or 99 or no fever, you anticipate the mother's suffering has come to the baby, but mother's antibodies are also coming through breast milk, and therefore the baby will get better earlier than even the mother. Okay, but be careful about it. Standard recommendation 3-month fever is a danger sign. But this is one example where a behavior of that baby being reasonably normal, she made a point breastfeeding to continue. And if that is happening, one would be almost right. This child recovered completely in the next 2 days, and the recovery was faster than the mother's recovery. How wonderful it is that a breastfed baby is well looked after in spite of all this infection.
Okay, we move on to the last case for today before we stop this session.
Irrespective whether tea is there or not.
Yes, sir.
Yeah.
A 4-year-old child presented with breathlessness for a month and has also increased in weight by 6 kg over the last 4 months. Any thoughts locally? No, he's not been given steroids, though there's a new mall next to his house. Nephrotic? No, he's not a nephrotic. Endocrine? Okay.
Thyroid.
Okay. So they feel it's a pathological increase in weight. So there's definitely something wrong seriously. He was diagnosed as adrenal hyperplasia and treated. After a week, he developed fever, which continued for a month And several tests were done to try and figure out the cause of the fever, and we couldn't figure out anything. And various drugs were tried, they failed. Any questions?
Detail of fever. Detail of fever.
Appetite and diet.
Yeah. So details of fever, what details do you want to know about the fever?
I want to know how much is the fever and is responding to paracetamol or not.
Yeah, so the fever was not responding to paracetamol. Why do you ask that?
I want to differentiate it peripheral from central fever.
Okay, fine. Appetite was good. There was no problem. And
How was the diagnosis made in this
Not
case?
responding to.
so I don't remember
It is-
how the diagnosis was made, but it was an endocrine thing, like it's a Cushing's situation. Yeah.
Since
And
the fever
a
is not
short period of
No, no.
weight gain of 6 kilo has to be adrenal. Okay.
Sorry? Someone
Body
said
symptom or peripheral.
to paracetamol, it is a central fever. So central
Okay.
fever. It is a
Okay,
central fever. It is not responding to paracetamol. So it is a central fever. We think of a tumor of a hypothalamus.
Okay, very good. Okay.
I think give him a clap on behalf of all of us. Sir, wonderful statement you made. And you told us that every time there is a fever, do ask what drug will bring down fever. This child exactly said, no antibiotic is working. Our friend said, it is a central fever. He added to say, it's a hypothalamic pituitary. It means it's an endocrine problem. And therefore, again, the dictum is, if one symptom and sign is endocrine, let another be also endocrine rather than going for another system. This is again a real case, and our endocrinology department did all tests for fever. Finally, they said, no, it must be central, but they said there is no way adrenal causes that. Then, of course, the fellow went on literature search and found out some syndrome where even a hypothalamic and adrenal go together. The point is what our friend there meant. And I think it's a lesson to all of us. Just ask one question, what happens after paracetamol? Another time that a patient of fever, I must ask is whether the feet and the abdominal skin are equally hot. In a high fever, the periphery is always cold. If periphery is hot, it's simply a heat fever. Don't investigate. Cool him down. So two things we learned about asking for fever, right? But I must congratulate person. Could you name yourself, please?
Dr. Vivekanand Sinha Gaya.
Oh, wonderful, sir. Excellent. We clap for your thing.
Okay, so we've come to the end of this session. In the last 2-3 minutes, if there are any questions from anybody locally, we can take that, or we could have a question from the online people, anybody. We have just 2-3 minutes.
Sir, we have a question.
Yes.
Osteomyelitis case.
Yes.
In the question, the polymorph was raised for 80% and TLC was 80,000. That was not that justified for non-inflammatory.
No, sir. So the point is that there are many situations in rheumatology where you get a high count and high poly. So high count, high poly is a sign of acute inflammation. In practice, most of the times it is acute infection, but it can also be a non-infective inflammation like a rheumatological disorder. We know that systemic onset JIA often has a very high count. Juvenile idiopathic arthritis has a high count. So high counts do not necessarily mean bacterial infection. So that was the focus, that it is not evidence of a bacterial infection. We have to look at it clinically. So the clinical story didn't fit. Any questions here?
Okay, sir.
Sir, any correlation of platelets in this condition?
So platelets do increase in rheumatological conditions, but they take time. So that will happen over 2-3 weeks, not necessarily in the beginning. Okay. Any other questions from anybody? Okay. Here, any questions from anyone on any of the cases or even otherwise?
We want tea.
Hello. Hello.
That's what is not ready, sir.
Okay.
There's a query
Okay,
from
okay,
Hyderabad.
query.
Hyderabad.
Yeah, yeah, please.
The query is, what does ECOT stand for in this expert thing, sir?
What does accord stand for?
Stand for this expert workshop.
Okay. Anybody from Alchem wants to tell how the name accord was generated? Okay. I think it has been, there's a new generation of Alchem people here, so they don't know what is the origin of the word accord. Okay.
So, different question.
Yeah.
Me antihistaminic for less than 6 months child for common cold.
Antihistaminic for less than 6-month-old child for common cold.
Histamine never works because histamine is not the only one. There are so many of them, 100 by now. And therefore, antihistamine is only for a very transient, temporary, maybe itching. And itching also, it does not really restore, but you fall asleep and therefore you stop itching. So antihistamines have a very, very limited occasional use, SOS use. Otherwise, gone are the days when allergy was histamine and the treatment was antihistamine. No more now.
Sir, URTI management in the less than 6 month age. URTI management in less than 6 month.
URTI management in less than 6-month-old.
Well, first thing is URTI is not so common under 6 months. That's number one. If it is so, then possibly you just keep a relief in mind, forget the disease. So what's the reason of having some disturbance? Maybe a nose block, simple and normal saline drops. What else? There is no need to use any drugs whatsoever. If there is a fever, you use paracetamol. That's it. And I think therefore URTI for any reason, make him happy till the nature cures the disease.
Sir.
No, sir. I think the child with the TB meningitis, why can't we think of immune encephalitis here? High fever for 3 days, followed by unconsciousness and seizures.
No, it's a possibility. Surely it's a possibility. We discussed that this child is now 3 months down the line. So hydrocephalus is usually a sequelae of a infection. Either bacteria, I mean tuberculosis more common, sometimes bacterial. So that is a strong point. Of course, we'll have to get into the details of the history that time. And usually, or at least some majority of the times, autoimmune encephalitis have some different kind of symptomatology. But you're right, it cannot be ruled out completely, but it's just circumstantial evidence which points to tuberculosis as a possibility.
Regression of milestone is another possibility of encephalitis.
No. So regression of milestones, as in, see, this child was normal till that illness. And post that illness, this child is looking considerably delayed. Now, we know that after TBM, these children are, in a severe case of TBM, they are quite, they're quite damaged in terms of multiple functions. So that is the question. So regression, we will really be able to talk in a child who's had a milestone, who's lost it over a period of time. So in a acute CNS illness, the difference in ability post illness and pre illness is not really called regression of milestones. Regression of milestones is something which happens slowly over a period of time. And that's a different set of conditions.
Ambedkar sir. Hello, Ambedkar sir. I have one.
Yes. Go on.
What is the role of hypertonic nasal saline, sir?
Hypertonic nasal saline.
These days in the market, they are moving like.
I think hypertonic saline for nebulization, you mean?
No, sir. It's. I mean, high nasal. I tell the brand name. High nasal saline drop. Ambedkar, sir, please.
I have a better person to answer. Amdekar sir's response suggests that he has not even heard of it. Forget use it. So that is his response.
Yeah, again, hypertonic nasal saline, it's anything which is unheard of, and if at all it is, please don't use it. It will just increase the osmolarity of your nose, which will further increase the nasal irritation. So please don't.
Sir, one question, sir.
I think this situation is similar to in one of the earlier sessions 2 weeks back on antibiotics. I asked Suhas Prabhu sir, what is the role of ferropenem in OPD practice? And his answer was, what is that? So this is a similar situation.
Sir, one question, sir. How do you treat red eyes in children? Red eyes.
Red eye has a very huge differential. So I don't think we'll be able to, just categorize red eye as one condition and treat it.
Hello.
Hello.
Sir, I want to know.
Okay, now some local questions. So online can just listen. Yeah.
Exactly at what age do the beta receptor develop to respond to our bronchodilator?
So there's no fixed age, sir, but I think before 2 or 3 months, the chances are very low. And therefore, in that gray zone, we can give a trial and see whether we are seeing a unbiased response. But you will not be able to say, right, Kostub? Beta receptors in infants?
The recent evidence says that they completely mature by 6 months. So before 6 months, they are in a transition phase, as Sir rightly said. 2 months and below, probably they are not. They're just in the primitive phase. From 2 to 6 months is somewhat they are partially making. So that's the reason for initial. You have any airway malicias, we try to avoid all these specifically because if at all they are present, they could further worsen the problem rather than making it better.
Fine. So I think we stop here. Thank you so much, all the online audience from all the 12 centers. And thank you so much, all the local audience, for a wonderful interaction and a wonderful piece of learning. Thank you. I think I hand over to the Alchem people here. Thank you.
Thank you, Dr. Amrega sir and Dr. Chukhani sir, for this wonderful deliberation. So before we dismiss for tea, so I would like to clear a certain doubt that was asked during the quick Q&A session. That is what ACCORD stands for, right? So ACCORD is not necessarily an acronym. So it stands for harmony, right? So if you look below the thing, it stands for expert consensus. Yes. So as a part of a medical fraternity, it's very important for us to arrive at a consensus or rather a harmony. So we need to be unified in our medical approach. We need to be unified in our treatment protocols, and we need to be unified in our scientific ideologies, right? So that is what ACCORD stands for. Yes. Thank you. And we'll be regrouping in 15 minutes. Thank you.
Everywhere there is a break for 15 minutes for tea. So we reassemble after tea and there will be deliberations on other topics. So please reassemble in 15 minutes everywhere.
Presence of NSM sir, Mr. Susil Kumar. Please hand over the salts and memento.
check, check. Hello, 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 check, check. Hello.
वहाँ का नहीं, वहाँ का बोल। हेलो। हाँ दिनेश भाई। हाँ आ रहा है सर, आपकी आवाज आ रही है, मेरी आ रही है? नहीं बोलो कुछ, आवाज नहीं आ रही आपकी।
हेलो सर, मेरी आवाज आ रही है आपको?
Hello, hello.
Yes sir, so I can hear you very clearly. Now it's done. Please shift, use it. Board is live. Okay, done. Thank you sir.
मेरा आवाज आ रहा है?
एकदम क्लियर, मस्त, परफेक्ट, कड़क.
थैंक यू, डन।
Thank you, done.
अभी चेंज मत करो कुछ सेटिंग।
हाँ, इसको इसको क्लोज कर दो, बस सेटिंग चेंज मत करो बस.
सेटिंग चेंज मत।
Dada. Thank you very much for Dr. Shailesh Chandra for his valuable inputs during the first session. So I would like to call up on the stage uh,
हेलो हेलो हेलो। हो ठीक है। हाँ।
कंफर्म बोल दो डॉक्टर को. Solve, madam. Now it's two way. Have the two way working.
सर नॉर्थ में 100 ईयर्स पहले
अरे निशान जी, उनको बोल दीजिए नागपुर जब मैं नाम नहीं अभी वक्त नहीं, तो अभी कुछ अफसोस करेगा, कुछ सुनना पड़ेगा नहीं. अभी डायरी पर
बात कर।
Hello, hello.
Hello. So we will be regrouping in 5 minutes. And yes, so we'll be going live in 5 minutes. So please regroup accordingly.
तेव्हा हे completely different असेल.
So, moving on to the second session for tonight, the topic is controversies and consensus in the management of vesicoureteral reflex in children. And for this, I would like to welcome our esteemed faculty, Dr. Rajiv Sinha, who is the professor, head of the department, Division of Pediatric Nephrology, Institute of Child Health, Kolkata. He has established the Division of Pediatric Nephrology at the Institute of Child Health, Kolkata, which is the first of its kind in an academic institution in Eastern India. He has completed the certificate of training in pediatrics with the professor, head of the department, Division of Pediatric Nephrology, February 2009, Kolkata. He has also done his fellowship in pediatric nephrology, University of British Columbia, Vancouver, Canada, which is the first of its kind in an academic. I will welcome sir, and before he starts the session, I will request Dr. Jaideep Roy to felicitate our speaker, Dr. Sinha. Thank you. I will now request Dr. Sinha to take over the session. Thank you.
Hello, hope I'm audible. So, first of all, sorry to the for Mumbai. Like I really wanted to come to Mumbai and have a chance to have some word and guidance from Dr. Ambedkar sir, and I really missed it. And I'd like to thank the Accord team, the academic team, as well as Dr. Chokhani for giving me this opportunity. So what I will do is like we have been asked to talk about the controversies in the management of UR. And we'll start with the first 5 scenarios. My request to those who are present here, as well as those who are present online, that so if I can go to the next slide, please. Yeah. So my request is that we will not go to the answers of any of this at the moment. We will go to the answers at the last. So you can take a clip of it, or we will come to the last and we can have the answer at that time. So we start with the scenario 1, which is a 2-month-old girl with antenatal. Sorry, 2-month-old. If previous slide, previous. 2-month-old girl with antenatal bilateral hydronephrouterosis presented with febrile UTI, MCG showing bilateral grade 4 B1. Next slide. So, which one of the following is the correct option? So, please take a screenshot of this and you can think about it while we are going through the talk. Next slide. Scenario 2 is a 10-week-old female with febrile UTI, E. coli positive, responded to IV antibiotic, ultrasound negative, MCG grade 2 reflux, as you can see. Next. So, which of the following option is incorrect? Incorrect. Please do take a screenshot of it. And next. Scenario 3 is an 18-month male presented with febrile UTI. Ultrasound showed that the left ureter is slightly dilated. MCG showed grade 2 reflux in the left side and right grade 4. DMSA bilateral scars. Next. And these are the options. So please do take a screenshot of it. Next. Scenario 4 is an 8-year-old female presented with, and you can see the child. You can play the video while I am telling the. So 8-year-old female with recurrent UTI with ultrasound mild bilateral hydronephrosis, MCG left cross reflux, and EMSA showing a card fever. Next, please. Because, yeah. So which one of the following options is the most appropriate? Please again take a screenshot of this. Next, yeah. And the last scenario is an 8-year-old girl with a recurrent UTI for the last 2 to 3 years. Because of the recurrent UTI, they did an ultrasound and an MCG. So you can see the MCG there, which is showing something. Next slide. So which one of the following is not an appropriate next investigation? So again, take a screenshot of this. So with this sort of a background, next, we will go to the objective next, which is to be crystal clear on next. What is VUR? Its epidemiology, clinical implications, and the current management plan. Next. So what is VUR? Next. Simple thing, like it is the urine going the reverse way up, and it can be unilateral or bilateral. We all know this. Next. VUR can be of 2 types. We can have a primary VUR or we can have a secondary VUR. Primary VUR is the congenital one, like born with the primary, born with the VUR. And if you look at the slide, in a primary VUR, your ureteric tunnel is short. So normally, if the question should have come in the mind that why doesn't the urine go back in everyone? Because you have a long ureteric tunnel, and when the bladder is distended, that long ureteric tunnel collapses. But if you look at the bottom, the ureteric tunnel is short. So when the bladder is full, still the ureter is not collapsing and the urine is going the reverse way up. Next. And this is very important to understand also is that how does the kidney develop? Kidney develops by an interaction between the ureteric bud and the metanephric blastoma. So the ureter comes up, it interacts with the metanephric blastoma and the whole kidney develops. If your ureteric bud is not coming up in a proper way, if there's something wrong with the ureteric bud, that means that you are having refluxes, and that is one of the reasons that many a time with reflux you have dysplastic kidney, and this is something important to remember. That with reflux we often have a dysplastic kidney. Why? Because of this. That there is a defect in the ureteric bud opening. So instead of the long opening, it is have a short opening. And because of this, they are not interacting well with the metanephric blastoma, and all that can also affect the development of the kidney. Next slide, please. And next we have got the secondary viewer. Secondary viewer is simple because of some obstruction. Obstruction can be physiological. For example, say a neurogenic bladder, particularly non-neurogenic neurogenic bladder. The bottom thing is not opening up properly. The bladder bowel dysfunction also. Or it can be something anatomical, like a valve, posterior valve, which we all know. Next slide. And we have to grade the viewer right from grade 1 to grade 5 by the MCT. Next slide. Next, please. So now let us come to the epidemiology of viewer. Next. This is a very difficult question. If you look at children who are having a febrile UTI, the epidemiology of viewer is ranging from 8 to 50%. We say about a third of them. Antenatal hydronephrosis 10%. If we do a MCG in a child, in a sibling of a child who has a viewer, it is about another 30%. If we look at a cohort of end-stage renal disease, who are going into end-stage kidney disease because of viewer, they are about 7 to 15%. But all of these are pathological person. Like they came to you because of something. They came to you because of urinary tract infection, because of antenatal hydronephrosis. Next slide. What about looking in a normal children? Next. Now, this is something nowadays very difficult. Like I'm sure no ethics will allow us to do a MCG in all newborn, all baby, all infant. That is not possible. But this was done before. So in this particular slide, what you see is there is two lines. One is the single line and the other is the dotted line. Single line shows a study which was done by Baker, and that was restricted to the children with UTI. On the other hand, dotted line is a study done in 1967 in Germany, and they undertook MCG even in normal children, just to see what is the rate of VIVA. And if you look at that, it seems to be quite similar, the incidence of VIVA. So in a normal children without any UTI and children with UTI, it seems to be quite same. Obviously, as the child grows up, that is the difference. As the child grows up, then the incidence of VIVA decreases or becomes static in those who was not having UTI. So they resolve, whereas those who are having UTI, they don't resolve. But initially, it seems to be almost the same. Next slide, please. This was a very interesting concept in the study. What they did was they retrospectively looked at a cohort of children who had undergone MCG. And then they divided them among those who had a proven UTI, like culture positive, RD positive, everything, fever, likely UTI, unlikely UTI, false UTI, and no data. Again, yeah. Again, what is very important, if you look at the white column, which is a false UTI. So they were not having UTI. Even they were about 2/3 of them, like 60% of them was not having reflux, but then the another 30 to 40% of them were having reflux. Next slide. So all this, I think we can agree on this, that all refluxes are not pathogenic. All refluxes does not cause UTI, and all refluxes are sometimes like you can have it in a normal children also. Next slide. So let us now go to the clinical implications of fever. Next. And this brings us to the multi-million, the crore rupee question of kaun banega crorepati, as is fever clinically important. Next. If we go back to our MBBS days, next. Fever causes UTI and recurrent UTIs. Next. It causes bilateral renal scars. Next. It causes hypertension. The scars can cause hypertension. Next. And it causes the end-stage kidney disease. Next. Quite scary. Like all of these things can be caused by fever, and the child can even lose the kidney. Next. So let us explore this in more detail. So this is a forest graph, forest plot, looking at the relationship between the fever and the pyelonephritis, and definitely fever increases the pyelonephritis. But if you look at the diamond, and if you look at the confidence intervals, it is more for the higher grade fever than the lower grade fevers. Next. How about further elaborating this? So this is from one of the analysis of the American Academy of Pediatrics when they were doing their guideline. And if you look at this, again, the same thing we can see. Next. That the incidence of recurrence of UTI is more in the grade 3, grade 4 refluxes, not in the grade 1 to 2 refluxes. But next, almost 2/3 of them, of children, and they had quite a good cohort, 516. Almost 2/3 of these children who were investigated with MCUG were having grade 1 and 2. So you are exposing them to MCUG to get to know that your child is having grade 1 and 2 refluxes. You are giving them radiations, etc., etc. But this shows that they are unlikely to have recurrent UTIs, and we also showed in the previous slide that they are unlikely to have pyelonephritis also. Next slide. So all VUR does not lead to UTI also. Next slide. What about UTI? So if you remember all the bad things, scary things, the UTI leads to scar. When it does, this is a analysis where they showed that the greater number of UTI is associated with increased renal scars. Next. And again, if we look at it, it is again the more severe VUR which are leading to scars. Next. This is very interesting. Quite old study from Great Ormond Street Hospital. Next. Where you are seeing that right at the first episode of UTI, 53 patients were already having scarred kidney. So of a 143, right at start, first UTI, 53 of them were already having scarred kidney. Just one UTI scar? Or is it that they were having scar even before the UTI? They were having dysplastic kidney even before the UTI. They were born with dysplastic kidney. Next slide. Next. Another very interesting observation was from the RIVER and the QT study. So RIVER study, I hope most of you know about it. It is a big randomized controlled trial done from North America, where they concentrated on children. Unfortunately, most of them were girls and were having between 3 and 4 refluxes. and then one group got antibiotic, another group did not get antibiotic, and they try to find out what its effect is on the recurrence of the on the UTI recurrence. So that is the reverse study, and the QT study is a comparator group. These children did not have refluxes, so these children had UTI. But when they did a MCG, they did not have refluxes, so they were not recruited in the river group. They were recruited in the QT group. And if you look at it, UTI, no UTI, it seems to be the viewer seems to be almost the same, 2% to 3%. Next. And now we have got definite evidence that renal abnormalities can be present even without like in UTI. So these were the cases where you were having some sort of a renal scars even without UTI. Next. So we come to another conclusion that all viewer does not lead to scar. Some of the viewer lead to scars. Next. Now, what has been shown is that, so we sort of, I hope we have clear that some scars, some children are born with scars, some children are acquired scars. And what has been shown is it is primarily the boys who are born with scars. And these are the children who usually progress to the end-stage kidney disease. On the other hand, girls are usually not born with scars. They acquire scars through recurrent UTIs. Next slide. And this brings to this very important concept of differentiation. We will cover it later also. That on one side we have got the congenital scars, which are predisposed to hypertension, renal failure more in boys, and whatever you do, they are dysplastic kidney. They will progress to end-stage kidney disease. Okay. On the other hand, you have got girls with a small amount of scars, low risk of hypertension, and these are usually from recurrent UTIs. Next. So all scars are not equal. Next. If you remember what are the complications we discussed, we said that VR will cause UTI, VR will cause scars, scar will cause hypertension. And in this study, what we are seeing is that yes, sometimes scars does cause hypertension, but again, it is usually when you are having a bilateral VR. So here they looked into the incidence of hypertension in children with reflux, and they found it is usually where the bilateral kidney is involved, bilateral reflux is there, then only you have a higher chances of hypertension. Next. Now, this is something, this is a cohort which is often quoted. It is a Swedish cohort. And what they did was they prospectively followed up these children with UTI for a long time. So at the average follow-up of 16 to 26 years after the first UTI, if you look at the ABPM, it seems to be almost the same. So in this, I would say that even if you are having UTIs, even if you are having scars, you are not having high blood pressure. But when they followed it up for longer time, next slide. So the first one was 16 to 26 years. This one was 41 years. Then you can see that slowly the graphs are separated. So on a long-term follow-up, scars can cause hypertension. But again, what they found was that it is the bilateral scars. Bilateral scars, bilateral viewer, where you are having the hypertension. Next. So all scars does not cause hypertension also. Next. What about CKD? So as I said before, that if you are looking into a cohort of children who have progressed to end-stage kidney disease, about 5% of them are having reflux nephropathy, like they are having refluxes. And we are saying that that is the reason that the child went into the end-stage kidney disease. Next. Next. Again, going back to the Swedish study. Next. Yes. Reflux can cause CKD and scars, but again, it is to the bilateral one, bilateral higher grade refluxes. Next. And this was true for short study as well as for the longer study. Next. Next. And this is a very beautiful article where they sort of showed that in these children who are progressing, who are having CACUT, this plastic kidney with refluxes, whatever you do with refluxes, you will ultimately, it will really not matter that much. The child will progress to CKD. Next.
Dr. Rajiv, Dr. Chokhani, you're from Mumbai. You've got 5 to 7 minutes to try and wind up, please. Yeah.
Sure, we'll do that. So that comes to the concept that viewer and that comes to that answer that why does treatment of all these UTIs and viewer has not decreased the chances of CKD. So all scars induced CKD are not equal. Next. I've already covered this. Next. So let us recap till now. Next. Yeah. So what we have learned till now, viewer is not uncommon among general pediatric children. Viewer are not same. Some cause more UTI, some viewer are born with scars. All scars are not same. Some are congenital, some are not. Some scars cause hypertension, some may progress to CKD. Next. And recurrent UTI is more with the, like if you are having the dilating reflux. So I would like to now move on to the next part and the last part in the 5 to 7 minutes which I have by saying that the meaning of life is heads they win, tail you lose. Next. So management of viewer. Next. So we will speak about the diagnosis and treatment. Next. Diagnosis, all these are there. Next. Ultrasound. Next. Yeah. So all of these are there, but MCT remains the gold standard. Neither the ultrasound nor the DMSA has been proven to be useful in diagnosing reflux. Next. So when we do viewer, we have to do, when we do MCT, we have to remember that MCT is not good. And you have to remember next about the Indian guideline. The Indian guideline says the first episode of UTI, if you are having a non-E. coli UTI and you are less than 2 years, then only do a MCT. You should do ultrasound in everyone, but if you are having an E. coli UTI, first episode, you don't need an MCT. The ultrasound is normal. So you need an MCT in recurrent UTI. You need an MCT in children less than 2 years with the non-E. coli UTI. And you need an MCT if the UTI has the child has an abnormal ultrasound. Otherwise, no. Next. Yeah. So these are the various options, and I will discuss them one by one. Next. About whenever we are discussing about prophylactic antibiotic, we should also be thinking about do the fever resolves by itself. And this slide says that yes, in younger children, African Americans, and those with the non-dilated fever, they do reflux, they do resolve. Next. There are a number of RCTs, and if you look at it, everyone has got a different idea. You will see some of them are no benefit, some of them are benefit in giving antibiotic and preventing refluxes. Next. So this is a summary. Next. Kidney scarring, no benefit. Next. Febrile UTI, no benefit. Next. Febrile UTI, low grade, high grade, no benefit. The only benefit it seems is at the moment is that cotrimoxazole will increase your risk of further UTI with complicated UTIs like resistant UTI. Next. We have to remember this, all of these studies were having, most of them were having low quality. Next. And we were not really examining apple with apple. What about the grade of viewers? Some mention, some did not. Most of them are avoiding grade 5 viewers. What about the gender? The reverse study was about 80% of them were female. Next. And this slide shows that high incidence of antibiotic resistance, which we all know about, which is the hot topic. Next. What about the other thing about surgical interventions? Where surgical interventions, only the febrile UTI, you'd see that the diamond is favoring that. But that is the surgical intervention plus antibiotic. So in the febrile UTI, it is favoring. Otherwise, no change. Surgery or no surgery. Next. 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 For endoscopy, again, no change. And then why the variable reports? Next. 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 So as I said, are we really comparing apples with the apples? Because we are not in many of the studies, we have not gone into all this. And of this, I would like to particularly concentrate on one, that is the bladder dysfunction. Next. Because nowadays people are saying that we have been barking up the wrong tree. We have been ignoring the bladder dysfunction. Next. And even in the bladder bowel dysfunctions, and even in the reverse study, they said that in that group it might help, provided you are treating the bladder bowel dysfunction. Next. Because bladder bowel dysfunction increases the incidence of UTI by 2 times. So it is very important that you are treating the bladder bowel dysfunction. Next. I will not go into the details of the bladder bowel dysfunction treatment because that itself is a separate talk, but this summarizes it. Next. What is most important is constipation. So we have to treat the constipation. Next. And we have to evacuate the bladder. As long as you are evacuating the bladder, evacuating the bowel, your chances of UTI decreases sometimes. Next. It can be quite difficult. This child has a mitrophenol done for draining the bladder and has a mace done for clearing the bowel daily. This child was having neurogenic bladder. Next. Other prophylactic measures like circumcision, yes, is helpful. Cranberry juice is useful, provided you are taking it in good number, good quantity. Next. So in conclusion, I promised you that I will give you a clarity, but maybe this is what you are having now. Next. Next, and whenever you are having a confusion, we usually follow the guidelines, and there are number of guidelines, right from the NICE to the NICE Canadian and to the our Indian guideline. I would like you to concentrate on the ES. So which are the guidelines which are saying for UTI you do ultrasound, MCUG, DMSA, and you'd see this ES is more nowadays with the surgical. The EAU is the European and the one below is the American. And they are saying yes. So the guidelines coming out from the surgical comrades are more aggressive. Next. Next. And sorry, one slide before. And one slide before, yeah. And this was a study done where they also concluded that yes, surgeons seem to be more aggressive in investigations. Why? Next slide. Maybe because they have their own specialty trait. They are tall, dark, handsome usually. The surgeon with whom I work is quite tall and handsome, and I feel very bad about it. And they are focused. Like ये कर दो, इसको देखा जाता है. Next. So take home message at the moment will be, I would say that follow the guideline. Unfortunately, but think it over. So we have got the ISPN guideline. I've already covered the UTI part, and lastly, next, I will cover the primary viewer part and aim here. So the primary viewer, the guideline says for the low grade viewer, no UTI, no antibiotic prophylaxis. If there is a bladder bowel dysfunction, and that is the most important, then you have to think about the antibiotic prophylaxis till the bladder bowel dysfunction is treated. On the other hand, high grade viewer, antibiotic prophylaxis, but don't forget the bladder bowel dysfunctions. And if you are having a recurrent UTI, what we say breakthrough UTI, then you can think about the surgical intervention also. So next, so let us now go back to the scenarios. And I am not sure whether we'll have the voting here, but I hope you have taken the screenshot. Next. So which one of the following up?
Dr. Rajiv, sorry, you'll have to wind up quickly. Sorry.
Yeah, my last 5. So I hope I'll not then ask you any questions on this. So here the right answer is she needs next. She needs prophylactic antibiotic. Next. Next. Here the right answer. Next. MCG was not indicated actually. If you look into the, this was the E. coli UTI first episode and there was no ultrasound was normal. Next. Next. Yeah, here, next. Here, the ureteric reimplantation, we already said, it is not that useful. Next. Next. Here, this is a true case, and the main reason I wanted to show you this video was that this is an 8-year-old child coming in NAPI. So that really means that the child is having some bladder dysfunction. Next. And if this child turned out to have neurogenic bladder, next. Yeah, so a neurogenic bladder, abnormal UTS, and this child required a CIC and the proper bowel and bladder management. Next. My last scenario. Next. Next. One slide before. One slide before. Here you see, next. Yeah, here you see that the bladder neck is not opening. So this is child is having a bladder bowel dysfunction, the bladder dysnergia. Next. And easy way to find is not a urodynamic study, but a uroflowmetry with EMG. Next. Next. And that's what we did. So when your bladder is empty, your pelvis floor has to be relaxed. But here we are saying that the bladder is empty, that the use floor, there is a lot of activity in the pelvis floor. So the child is having a BVD, and most important cause is constipation. Next. So thank you very much, and I'm ready for any questions, if any. Thank you.
Yes, thank you, Dr. Sinha, for this wonderful deliberation. It surely was an excellent session. So, moving on to the next session for tonight, the topic is how to choose an antibiotic. And for this, I would like to invite and welcome our esteemed faculties, Dr. Vijay Yewale, IIP President 2014, Head of the Apollo Children's Hospital, Navi Mumbai, Director and Consultant, Dr. Yewale Multi-Specialty Hospital for Children, Navi Mumbai, Editor-in-Chief, Pediatric Infectious Disease, the Journal of IIP, IIT Chapter. Dr. Baldev S. Prajapati, Professor, GCS Medical College Hospital and Research Center, Ahmedabad, 92 publications in various journals. He has been an executive board member, Central IIP 2002, 3, 5, 6, and 2010. He has been the president of IIP Gujarat State Branch 2003, chairperson ID Chapter IIP 2009, and member of IIP Committee on Immunization. Yes, thank you and welcome, esteemed faculties, and a request to take over the session. Thank you.
So very good evening. Let's move back to our interactive sessions. And I have with me none other than Dr. Baldev Prajapati, a very senior pediatrician from Ahmedabad. And he is a professor of pediatrics at GCS Medical College. And I'm sure he does not need any introduction. And
No introduction.
Baldev, yeah. So what we have been asked to discuss is, this is the previous, how to choose an antibiotic. It's a common, I would not call it dilemma, but we use antibiotic day in and day out. And since maybe last 1.5 decade or so, we have been trying to sensitize on the rationalizing use of our antibiotics, and the reasons are valid because AMR is an ever antimicrobial resistance is an ever growing problem, and it is estimated by 2030 there will be 10 million individuals who would be lost to resistant infections per year, and it is going to have a huge impact on the economy, also the GDP. And what drives the antimicrobial resistance is the use, overuse, and abuse of antimicrobials. So what is needed at this point of time is to rationalize use of antibiotic. Now, if you look at the use of antimicrobials, we use it either for prophylaxis or for therapy. And therapeutic use, definite is the ideal use. I mean, where you know the pathogen for sure, you have the culture antibiotic sensitivity from whatever specimen you have, sent for testing, and you know the what antibiotic the bug is sensitive to. But unfortunately, this is, though ideal, is not feasible in all these situations. So most of us resort to empiric antibiotic therapy, at least to begin with. And as the results come, in some instances, we modify our therapy. That also does not happen uniformly across. And once we start something that is continued, we don't de-escalate or we don't narrow down the spectrum. So though empiric, it has to be an educated guess, and one can definitely be rational. So in next 45-50 minutes, what we intend to do, we would discuss between two of us in your presence. We'll put up some cases, and if you go home with this 5 questions that each one of you would ask before penning down an antibiotic when using empirically,
I think Dr. Vijay will not discuss, they will discuss.
Yeah. So what is the probable pathogen? What is the site of infection? What is the severity of infection? Is there a host comorbidity? And am I anticipating a resistance upfront? If you answer these 5 questions with every case scenario, I think our job is made. So let's start with this first scenario. We have a 19-month-old girl who has come to with 1-day fever. The fever recorded was 101. This is a staff nurse who came to me day 4 yesterday. The child also had mild cough and cold, and she works with Apollo, and we have a creche facility. So the child is kept in the creche, and that day she, from her duty, went down and brought the baby up. Physical examination is normal, and mother is anxious. And these are the options. Would you ask for CBC urine routine, or just prescribe paracetamol and saline nose drops? Or since mother is anxious, she's a staff nurse, high-grade fever, an infant 19-month-old young child, would you start coamoxiclav or azithromycin for the dosing convenience and short duration of therapy of 3 days? So let's vote on this. Yeah. Can we have voting on this?
Yes.
Oh, I'm so happy.
Yeah.
That our audience is really learned one. Now, Baldev bhai, somebody has said CBC, though majority have said that they would give symptomatic treatment. I'm worried. This is a 19-month-old child. She's staff nurse working in my hospital. I want to play it safe, and I don't want to miss out on anything. So, am I not, justifying sending some test and start an antibiotic? What is your view?
I think before I answer, let me know from the audience. I think everybody is worrying. And that's why that is the reason that most of us go for the prescription of the antibiotics. But what Dr. Vijay asked, anybody would like to respond from this audience, sir, please?
I've described this scenario again.
On day 1, we rarely diagnose any disease. By doing those CBC, urine is all useless. We have to wait, counsel the patient, counsel the parents, and call them back tomorrow again.
Sir, we do not diagnose disease on day 1, agreed, but there are diseases which can be disastrous if not started on antibiotic on day one. So a child with red flags, meningitis. I mean, I'm really worried. Irritable child. Why is this not meningitis? It will present with 1 day fever to begin with.
Anybody else? Anybody else?
Pattern of fever. Yes, please.
If it is a continuous high grade fever, the child is irritable and not, I mean, 19 months when like not feeding well or not eating well. Continuous fever is definitely a red flag sign. I think.
Okay. Baldev, my question is.
Yeah, now you can ask me.
We always keep talking about not to miss out on urinary tract infection, especially in an infant in the era of Hib vaccination, pneumococcal vaccination. Those causes have been taken backseat. UTI is something which one did not miss. So am I not justifying asking for urine and start the child on an antibiotic?
I think all of us know that that is the reason why we jump either for the investigations or the antibiotics, what you say. But very definitely we can go in the further, I will say, details. As very rightly you said, fever of 1 day. I'm sure that even you said that the mother is working and child is crash. Probably this child is more prone to develop these viral infections. Even we can ask in the details in between the febrile period, what is the condition of the patient, even what is the activity of the child, whether child is even better responding to the paracetamol or the antipyretics. And I am sure that even some other children are suffering from similar problems or many times in the family itself. I'm sure that the reason is probably we don't go for all these details and we jump for this. Yes, all these reasons are there. We agree. But I'm sure that if we go in the details, probably most of the times, may not be every time, but we'll be clear that yes, it looks more of the viral. And certainly if you have some reason to suspect or consider that condition, I think it's justified.
And
but every child, without going all the details, that is, I will say, not justified.
And he made a very valid point. He would like to know the pattern of fever.
Yeah.
So again, let's make it a rule to ask a few questions when a child has fever. What is the fever like? What is the degree of fever at onset? What is the progression? How is the child in between fever spikes? How is the response to paracetamol? And are there any associated symptoms? If you ask these 4 or 5 questions, more often than not, it will be easy to delineate a bacterial from a non-bacterial fever. So if you get into habit of asking these questions and go into the little detail of fever, one can really, decide on whether an antibiotic is required or not. But by and large, fortunately, the Lord is very kind.
Yes, sir.
And most of the garden variety infections are viral and one needs to resort to symptomatic treatment. That's an extremely important question that she has asked. This child has been started on azithromycin and he's come to you on day 2. What would you do? Would you discontinue or you would continue? Because there is a notion that antibiotic once started should be completed.
Again, I will go back to the same, I will say, series of the questions, which suppose convinces me that it is more of the viral. Please, we should not have any hesitation to stop the antibiotics.
Yeah.
To stop the antibiotics. It's not so that already started, somebody has given for a day or two, then let us continue. I think that is also a very important question and message. Here, I think once you feel that it is not indicated, stop it. And even further, you can follow. And suppose the time comes that I have to restart, without any hesitation, we can restart.
So let's get out of that myth that antibiotic once started should be completed because of fear of promoting development of resistance because of partial exposure. So if it is not indicated to be given, you must stop it at the earliest possible. So mind you, friends, acute febrile illness is the commonest scenario that we see in our office practice. Fever usually indicates infection. However, all infections are not bacterial. And in the first session, we saw a good number of inflammatory conditions. And then a few bacteria can self-heal without antimicrobial. Say, example, mild otitis media. You have, mild non-typhoidal salmonellosis, which does not require any treatment and they are self-healing. So it is not necessary to jump to using an antibiotic. And these are the 4 or 5 questions that we were talking about. And Rajesh is also part of we are vetting this, simple rules. And maybe in another 6 months or time, so our study should be out so that we are able to give some guidelines or a sort of a practice rules for practitioners that if you ask these 4 or 5 questions, and objectively score, it will not be difficult to, decide on the need of an antibiotic in a child who presents to you with fever. Okay, let's move to the second case. 5-year-old boy, fever without focus for 4 days, liver just palpable, spleen just palpable, normal counts, neutrophilic counts, platelets 2 lakhs, CRP is elevated, and somebody has clinically suspected some enteric infection, probably typhoid fever or paratyphoid fever, and has sent blood culture. Now, having done that, fever is there for 4 days, child is being seen on OPD basis. What would you do? Would you start cefixime, azithromycin, or coamoxiclav? Let's have voting on this. So,
Still changing.
yeah, because there are many participants,
Yeah.
190 have voted so far. And majority of the participants think that cefixime would be the right choice of antibiotic. And let's interact with one of the virtual centers. Let's go to Indore. I can see Sanjeev sitting there. Sanjeev, would you like to come in? Yes. Would you start an antibiotic in this child who is having fever for 4 days and elevated CRP, normal neutrophilic counts, platelets 2 lakhs, and your blood culture report is awaited? And the fever has been there for 4 days, documented fever.
Yes, sir. So 4 days of fever, fever still not localized. Child otherwise all right, and counts are almost toward the normal side with raised CRP, and blood culture has been sent. So I think the entire clinical picture fits in enteric fever, and I think I'll not be wrong in starting him on, because cefixime, most cases of enteric fever, they are fluorocolor resistant. So I'll not go for other antibiotic, and cefixime usually they are sensitive to cephalosporin. So my choice would be cefixime in this child.
What dose of cefixime would you like to give here?
20 milligram per kg per day.
Or would you start 10 mg per kg, look at the report, and then raise it to 20 per kg?
Oh, no, sir. No, sir. Straight away, the dose for enteric fever is 20 milligram per kg per day.
So very good. So there is a reason behind starting antibiotics. Somebody has clinically suspected enteric fever. So probable pathogen is Salmonella typhi or paratyphi. The infection doesn't seem to be very severe. We know that typhoid is a bacterial infection, but this child is being treated on outdoor basis. So Dr. Baldev, there could be a case for, if the child is not really very sick looking, one could wait for the culture report. Nowadays, automated culture, it flags at the end of 24-48 hours saying that at least a gram-negative bug is growing, and one can start later. But yes, I mean, if somebody decides to start, no problem. But then the dose has to be 20
Yeah,
per
I
day.
think in so many forums we are daily discussing, and I'm sure that the audience almost the same, even in our daily round, also categorize the fever. There are so many reasons for the fever. Here, very definitely that documented significant fever, and already we said that the fever of 4 or 5 days, it is without the focus. Once we come to the category of fever without the focus, I think it's a time to consider whatever the possibility clinically. With this, I will say some other history point, examination point, and even suppose basic investigations available, which already you stated, that here fever without the focus, CBC normal, almost total count is normal, liver and spleen just palpable, CRP is raised, at least probably indicating some inflammatory condition, probably infection, that to bacterial we can consider. And in this situation, plus I think very important point, you can start the antibiotics, but don't miss to collect the blood for the culture. I think
Yeah,
here
that
you
has
have
been
given the
said.
good scenario, but very important point. And here probably it is convincing clinically the enteric. Then you can start, I will say, cefixime and 20 milligram per kg per dose, very appropriate started. Wait even for the culture, but I think here I will not wait till the culture comes back.
Fair enough. But I mean,
We
they are
should start it.
we are very clear in our mind that probable pathogen is salmonella.
Yes.
And so we will start 20 mg per kg and not start 10
Certainly,
and then
certainly.
increase it to 20. Site severity we know. Sanjeev, let me come back to you.
I think even as you said, we can make it clear that it is looks enteric clinically, even non-complicated enteric.
Yeah.
And non-complicated, so therefore even the oral cefixime is sufficient. There is no need to go for injectable.
Sanjeev, let me come back to you. Some people voted for azithromycin.
Yeah.
What is your take on this?
Sir, we should reserve azithromycin maybe because of two reasons. Because that is only the last antibiotic which is left for us. Because in case if we use azithromycin excess, then we lose this antibiotic, and then probably if we get a bug which is resistant to cephalosporin, we are absolutely we have got no antibiotic left excepting for meropenem. And then secondly, azithromycin, it works very well again for anti-TB. So again, for these two reasons, we should preserve azithromycin, and cefixime should be the first drug of choice rather than azithromycin.
But Sanjeev, we said that the fourth question that we ask is probable resistance. So in this era, today in 2025, would you consider resistance and think of adding or preferring azithromycin over cefixime?
No, sir. I will not use empirically, definitely, because if in my area, if the epidemiology says that there is a lot of cephalosporin resistance, then only I'll consider. But in India, as such, for today, the incidence of resistant cephalosporin is very low. So I'll not definitely go for empirical azithromycin. I'll go for cephalosporin only, treat it, and in case if it is not responding, say after reasonable time, for about 8 to 10 days, I've given, and even if it is sensitive and is not responding, then probably I might change it over to, I'll not add, I'll change it over to azithromycin, but definitely it will be not empirical. It will always be after a reasonable trial of cephalosporin. If it is sensitive and not responding, say after 10 days or so, then probably I might use azithromycin.
Excellent. What a clarity of thoughts. He has explained everything very well.
Let me make the point clear. Yes, we do come across the problem of the resistance. It is growing up. I will say the problem of neighboring countries as with other problems. But somehow, fortunately, till probably it's not the big problem for us. If I quote over here, in GCS Medical College, where I'm working, probably the last 3 or 4 years, more than 500 cases of salmonella blood culture positive, which I'm going to publish in our infectious journal. Not a single case, we came across resistant to the cefixime or the ceftriaxone. Yes, in the Baroda, some pockets, but that also, if you go in the details, that was for the short time, very few cases, some different strains which they got confirmed at Vellore. I think if these are the situation and some pocket or some area outbreaks, okay, that we can take care, but we should not make it generalized for our daily practice.
Absolutely. So let us go very clear that we do see sporadic cases of ceftriaxone resistance, but it is not the norm in our country so far. So please adhere to cefixime or ceftriaxone in admitted patient of enteric fever, and don't be patient. Fever effervescence can take time. Don't use dual antibiotic because the outcome really doesn't change whether you use single or dual antibiotic. And let us spare azithromycin, because in our neighboring country where they have a huge problem of XDR typhoid, where it is resistant to the first line agent ampicillin, chloramphenicol, cotrimoxazole, it is resistant to third gen cephalosporin, and the quinolone resistance is almost to the tune of 97-98%. So what is left to is only azithromycin and maybe carbapenem. And carbapenem is a notorious drug with a very high resistance induction potential. The moment you expose a gram-negative pathogen to carbapenem, it quickly, tends to develop resistance. So please spare azithromycin, and let's not touch azithromycin unless it is truly.
Excuse me, what is the maximum dose of cefixime which we can use in enteric?
It is
in
600 milligram, 600 milligram twice a day, 12 and 1.2 grams is the ceiling dose.
Becomes as an adult dose.
Okay. Thank you.
Sir, we have few cases where ceftriaxone resistance has been shown in the blood culture, but clinically the child has responded.
So Himanshu, two things. One thing is you need to verify your ceftriaxone resistance by disk diffusion or broad dilution method. Number one. where there is many times there is a discrepancy. And secondly, as I said, it's not very common. And if your child has responded to ceftriaxone, I don't think you need to change because you double check on your resistance, the sensitivity by this diffusion of broad dilution.
Even this is also very important point. In few cases which were reported in the Baroda by Dr. Satish Pandya and other friends, but they were happy with the ceftriaxone. They said that the most of the patients, they responded to the ceftriaxone.
Sir, the problem here is we had such patients. We sent sample to Dr. Balaji at CMC Vellore, and the reports were wrong.
Yeah.
They retested with this diffusion or broad dilution, and it was sensitive to ceftriaxone.
That's why I think this point also to be kept
So
in
be
mind.
cautious before labeling a child as having XDR.
Probably true resistant may be the very minimal, if at all it is there.
Baldev bhai, tamari case.
Yes, yes.
Yeah, Dr. Vijay, please from Ranchi.
Yeah, please, sir.
Sir, it is important to continue cefixime at least for 14 days to prevent the relapse.
Absolutely.
Absolutely. Duration 14 days.
So beta-lactam antibiotics are no, relapse with beta-lactam is known. It is slightly higher than with macrolide, but that should not be an excuse to prefer a macrolide over beta-lactam like cefixime. About 4 to 5% patients do relapse, but then the relapse is lessened if you complete the duration, as he said, for 2 weeks.
I think 2 weeks is important.
Point well taken, sir.
Yeah.
So should we continue it for 2 weeks in the same dose?
Yes.
Same
Yes,
dose,
same dose.
same dose.
Sir,
Here I think
100 milligram is the upper dose, 20 milligram per kg body weight, and
correct.
Must be given for 2 weeks.
Absolutely. Yes. Sarji.
so. This was the 7 months male. Just I will say in the last probably 2 or 3 weeks back, we had the patient. Fever of 100, 101, multiple spikes 20 days, frequency of stool, vomiting, which you can say. Healthy child, 3.6 birth weight, 7 months weight was almost 8 kg. That means nutritionally, immunologically, child was quite competent. But having the fever, while this, I will say, variation of the vitals due to the fever, the rest of the things were normal. Even CBC normal. And somebody has, even this patient came after 15 to 20 days to us. The point was here, when the child was brought, only single spike of the 101 fever and there was no fever. Next. After that, and that's why because there was no fever, I said, let us wait, and we sent the blood culture. Blood culture came the positive, and meanwhile, before the blood culture comes, baby has started even the fever also. So even the 7 months old children having, I will say, odd symptoms and signs, not uncommon, even the enteric, that is the another point. And here, that was a dilemma. Should we treat? I said, yes, in this patient, we should. The only thing probably, rather than the cefixime, looking at the 7 months, because they are prone to develop the problems and complication or even the salmonella septicemia. For that reason, ceftriaxone may be the preferred drug and better to go for the parenteral. But 7 months old children with even the blood culture, I'm not sure whether was it due to the bottle fed, because the child was bottle fed. But the problem of blood culture positive is salmonella.
So a very clear-cut take-home message that enteric fever can occur as early as 7 months. Number one. Number two, now let's go.
Even one more point, Dr. Vijay, many times what we discuss that whether the 6 months typhoid vaccine is justified. I think even such examples, and not I will say it is so sporadic. So certainly probably the early vaccination is justified.
Now here we had a culture report and we'll discuss further definite antibiotic therapy. But with this scenario, pending the culture report, let's look at those 5 questions. Probable pathogen?
Yeah.
In a 7-month-old child with fever, which is going on for almost 20 days. Yes, Bharat bhai. Stool culture, I personally is in an immunocompetent child, stool culture is the most useless investigation that one can ask for on this.
I think nowadays even the same thing. We can ask the 4 or 5 questions and define, I will say, clinically, and we can try. Suppose here 20 days, definitely fever is documented, GI symptoms are there. We cannot ignore. That is very certain.
Probable bacterial infection.
Probable infection, and even the bottle fed, maybe even the bacterial infection. probably bacteria, which one here difficult to decide. Probably salmonella may not come in my thoughts. But yes, bacterial infection, and considering go for this, even the routine investigations, culture, even the urine culture should be taken in this patient.
Yes,
But
sir.
urine culture is also very
But
important.
most
And
probably a
start-
gram-negative infection
Yeah,
in a 7-month-old child.
absolutely, absolutely. And start the, I will say, appropriate antibiotics, which will probably works in the gram negative, either the UTI or salmonella.
One word of caution: in an infant who has loose motions, you need to be extremely careful while collecting urine for routine and
Yeah.
culture. Even a drop of fecal matter can make your results go haywire. And very often, febrile children with respiratory symptoms, you ask for urine, there is some leukocyte you don't
I think
exercise due precaution in
that's a very
collecting
big
urine.
chapter, Dr. Vijay.
Yeah.
But the point is, word of caution, that number one, collection of the sample appropriate, and even with that report, appropriate interpretation is very important to go for the diagnosis of UTI. But here, yes, UTI remains one of the possibilities.
So there is no debate on this. Ceftriaxone sensitive report is there, and 7-month-old child, would you continue ceftriaxone all through the 14-day course, or you will switch over to cefixime?
I think let me ask the audience, and then honestly, I will answer what we did. Anybody? See, we started the ceftriaxone, but the point is, should we go for all the 14 days intravenous, or we can switch on the oral therapy?
No, sir. As soon as the child gets better, he starts feeding well, and the child is clinically improving, and we can shift over to oral drug. There is no need to give ceftriaxone for 21 days, for 14 days.
Oral third-gen cephalosporins have very good bioavailability. They are absorbed pretty well. So if the child starts accepting orally, one may switch over to
Absolutely,
ceftriaxone. It may not be a full course either. Let us look at this child now. 12-year-old boy, 47 kg. Fever for 2 days, which is high grade, 104. Vomiting for 2 days and abdominal pain. The child gets admitted, has liver of 1 centimeter, spleen is just palpable. WBC done a day prior to admission is slightly on the higher side, neutrophilic with a high CRP. He gets admitted to our hospital, we repeat CBC, and WBC is normal but neutrophilic. Platelets are slightly on the lower side, CRP is very high. SGOT and SGPT elevated, SGOT higher than SGPT. And what will you start this child on? Child is vomiting, has high fever, 104, very high CRP, mildly elevated transaminases, normal count, neutrophil count, high CRP.
Let us take the opinion.
Let us take.
Yeah. Because that will give the good idea. Thoughts of the people.
Interact with a Delhi colleague.
Yeah, yes. मेरोपेनम वाले भी है,
कॉम्बिनेशन भी है. Okay.
I think let us take somebody from
Fine, Delhi.
Yeah.
Let's ask Delhi. My friend from Delhi. So majority of the participants have voted for ceftriaxone. There are about 15% who think that a combination therapy in this child is on card. Azithromycin, meropenem. I mean, there are a few voices who are talking about azithromycin, meropenem. So can someone from Delhi?
Dr. Vijay, you can ask somebody honestly, the person who has given the opinion and justification for the ceftriaxone and azithromycin combination.
So let's ask Delhi first.
Okay.
And then we'll ask one who has voted for azithromycin and
I think maybe
meropenem.
even here also.
We would really appreciate their, I mean, there must be some reason behind their thinking.
Yes, yes. Let us-
Okay, my friend from Delhi.
Hello.
Hello.
Yes.
Yeah.
Before we think of antibiotics, why can't we think of a possibility of dengue in this case?
Possibility of?
Dengue. I mean, non-bacteriogenic
Remove
causes.
this and let's go back to the case scenario.
You can go to the case scenario. Huh?
Yeah. Now, if you look at this history, the findings, and what are preliminary reports of CBC and liver enzymes, do you think a dengue would behave like this?
Okay, then there can be a possibility of abscess, liver abscess.
Count decrease. WBC was 12,000. Repeat after few days, it is come to the 7,000. And the abscess where these even the hepatic enzymes are also increasing.
Liver abscess can still be a possibility.
And child is not even the toxic.
He has a point that a child who has had high fever on day one with very high CRP and 104 fever with hepatomegaly, there is a theoretical, I mean, there is a, though low on the list, it could be, but clinically there could be some, evidence of hepatic tenderness. Generally, hepatomegaly would be little.
We have seen a lot of
more than
cases
just
without
pulmonary.
tenderness also. Sometimes they left low.
I agreed. I agreed. Your point well taken.
Dr. Vijay, just for the explanation, you know that any abscess for development and destruction and the collection will take some time, not in a day or two. Very
Unlikely.
Unlikely.
And secondly, the counts would not drop.
Not drop.
In liver abscess. Okay. So, who has voted for meropenem? We would really want to know the thoughts behind, thinking of giving meropenem.
I think just to know the reason or thoughts, ideas in your mind, not I will say for why you have given. Anybody, even here also.
Investigation like blood culture and start antibiotic like ceftriaxone.
Okay. Okay, fine. So, let's move on with this case. So, ceftriaxone was started as suggested by majority of the participants. Blood culture came at the end of 48 hours, which was identified as Salmonella typhi, but the antibiotic susceptibility report was pending. The child continues to have fever on ceftriaxone. Now, what will you do? You will continue ceftriaxone, add azithromycin, change to azithromycin, or change to meropenem. Lucknow, can you come back on this? This is a case where Salmonella has been identified. We are awaiting the culture antibiotic sensitivity report, and the child continues to have fever on ceftriaxone.
Continue ceftriaxone because it will take a little time to respond.
Let's have quick voting on this because other centers are also participating in the audience sitting here.
We'll get the more opinions.
Let's have voting on this.
Yeah. More opinions.
Continue ceftriaxone.
Okay. So about 1/5 of the participants are thinking of adding azithromycin
But even
also.
significant numbers, 18% is not less to add
Not
the
less,
azithromycin.
Yeah. So here we move from empiric to definite therapy. Empiric therapy, everybody was, of uniform opinion, except a very minority who thought of giving azithro or meropenem, but ceftriaxone, which we started. And on day 3 of ceftriaxone, the child continued to have fever. We have identified the pathogen. It is still a sort of an empiric choice because we do not have definite culture antibiotic sensitivity report. But majority have said that we would adhere to ceftriaxone. And all of us know that it takes time for the fever to come down in enteric fever.
I think
We
message
will
should
start
also be that continue to use ceftriaxone. There is no need to go for change of addition.
And there is no need to add also.
Yeah.
Correct. Okay. Now this child, the sensitivity was made available next day. This was XDR typhoid. So resistant to the first line agent. First line, that is MDR typhoid, ampicillin, chloramphenicol, and cotrimoxazole. Resistant to quinolone and resistant to ceftriaxone also. It is sensitive to azithromycin. The blood report says it is sensitive to amikacin also. And it is sensitive to carbapenems. Now, what will you do? Continue ceftriaxone. He was started on azithromycin 250 milligram twice a day. So you will make azithromycin 500 BD or change to meropenem. Let's have voting on this. Quick voting and then we'll discuss. Okay, first and foremost, this case is being displayed only to understand the thought process and to, sensitize rational thinking. XDR typhoid is not a common problem here at this point of time. This is one of such sporadic cases, number one. Number two, majority said that they would add azithromycin. I mean, they would change up the dose. The dose of azithromycin in enteric fever is 10 mg per kg per dose, and the duration is 7. Most of the studies have been done on 7 to 10 days duration. So you can give up to 10 days. And but I did not put that option. But would you continue ceftriaxone now, having a definite report of ceftriaxone resistance? So how many of you would continue ceftriaxone in this child with azithromycin? You'll add or change to azithromycin. Pardon?
Change to azithromycin. Will not give ceftriaxone.
Okay, Sanjeev is saying he'll change to azithromycin.
And I
Dr.
think
Chaudhary wants to say
here
something.
also very important message. Suppose by chance if we decide, then go for change, not the addition.
He wants to say something.
Yeah.
So, how is the child doing clinically?
Clinically, yeah.
Clinical child is going to have fever.
Doesn't have fever.
He has fever. Appetite is also still not very great. But he's not very sick looking. And fever has just started. It was more or less continued, has started spacing out a little bit. But all these are subjective, findings, except the temperature record, which showed little spacing out. So how many of you would continue ceftriaxone and add azithromycin? Please raise your hands. So you have a divided house. Maybe the child is having high fever. So see, once you have the antibiotic sensitivity report, ideal is to go by the sensitivity report. Now, can I ask those who raised hand that they'll continue to use ceftriaxone? What is the reason behind it? Why would you continue ceftriaxone?
In vivo and in vitro, the things may be different. So that's why the ceftriaxone should be continued.
I would also think of an abscess developing.
No, but you have
like cholecystitis.
No, but how would your antibiotic choice change? Even if there is a complication of typhoid fever, you have a definite sensitivity report where it is ceftriaxone resistance. Continuing ceftriaxone, somebody said in vivo and in vitro. So would that, would you be comfortable continuing ceftriaxone?
No, sir. Definitely, ceftriaxone has to be stopped.
Yeah, because here in Salmonella, we know that there is the report is indicative of XDR typhoid. I think most of us are scared of continuing a patient on oral antibiotic. Mind you, azithromycin has excellent bioavailability, number one. It penetrates extremely well into intracellular compartment. And that is what you need in treatment of typhoid fever. So please do not hesitate, even if it is an oral antibiotic. It works wonders. So azithromycin, it should be changed to azithromycin. Anyway, let's continue with this patient. So this patient, after 2 days of 500 milligram of azithromycin twice a day, the child continued to have fever, but now the fever was definitely spacing out. Child was looking subjectively better, had started eating a little bit. Now what will you do? Would you continue ceftriaxone and azithromycin, or stop ceftriaxone and continue only azithromycin, or add meropenem and stop both ceftriaxone and azithromycin, or stop ceftriaxone and add meropenem to your azithromycin? Vote. Okay. So let's interact with some virtual participants. Somebody from Gaya, would you like to come in? So the majority of participants saying that azithromycin should be continued. What are your reasons behind continuing azithromycin? I said fever has started spacing out. Child is looking a little less toxic. And 2 days of appropriate dose of azithromycin have gone in.
Sir, the child is responding well, and the fever is spacing out. The child
Sanjeev,
is
Sanjeev, can I interrupt you? Somebody from Gaya wants to come in.
okay.
Or even from some other place, if voluntarily somebody
I
ready.
can see my friend there in Gaya
Yeah,
holding a mic. We are unable to hear you, sir, but.
I would like to continue azithromycin and stopping the ceftriaxone.
But sir, the child is still having fever.
Yeah, I do CBC, and if the trend is showing the increasing WBC count and increasing eosinophil count, and the child is showing improvement, then we continue the azithromycin. And
Sir, the counts were 5,000. If I tell you that I repeated the counts, 7,000 counts were 7,000. And if I told you that the counts were repeated and they were now 8,200, but still neutrophilic, and platelets have dipped further to 1.2 lakhs.
Lymphocytes counts.
Neutrophilic count. Would you how would that impact your decision?
Even I'd say, Vijay, one message should be clear that this CBC is not going to help you.
Yeah. So that is what I'm trying to come to that.
Increasing total count and increasing lymphocytosis and eosinophilias. Eosinophil is coming. It shows an improvement.
Okay, he wants to say that if there is a switch from neutrophilic to lymphocytic and eosinophils start appearing, it would indicate a recovering infection.
Yes,
Sir, but forget about the counts. It is more important to see the clinical progress of the child. The child is improving.
Absolutely.
The child is improving. We should not deviate from our line of treatment.
They have started azithromycin and it is yet not completed for 5 days or 7 days. It takes time to have
Absolutely. So my friend Sham Sidana has made a point that it takes time for the fever to come down. If the child is clinically appearing better, though there is fever,
Even the
one
point
need not
is, I
worry.
would say repeating the CBC does not help in making the decision. That should also be the very clear message.
Fine.
And secondly, even sometimes after completion of 7 days also, suppose child is absolutely fine and some degree of fever, don't bother, wait for some time, probably it may recover by its own.
Okay, but at the same time, a child who was appearing little better has started spiking again, or the response is not as per your expectation. You do a repeat count, and then you repeat liver enzymes. They are increasing. There's hepatomegaly, sick-looking child.
Always
One
seek
would
for
keep
the, I will say, what we say complication first.
Yeah.
Rather than chasing the antibiotics.
Correct.
And complication even in the enteric is also fairly common. Maybe the anything, cholecystitis, abscess, somewhere collection, anything is possible.
So let's have a quick vote on this next patient. 11
Sir, I am from Delhi. I have one small question.
Yes.
Sometimes the blood culture report shows the sensitivity to quinolones. Can we add quinolone with azithromycin?
So, two things. The law of the land does not allow use of quinolones in a child less than 12 years of age. Secondly, quinolone, if it is sensitive and the child is more than 12 years, and if your other drugs, you have better studied and safer drugs available like ceftriaxone or cefixime, I would still go with cefixime. It is unlikely that you have a child who has enteric fever who is sensitive to quinolone but resistant to ceftriaxone. So quinolone by and large is not really, a preferred drug in treatment
Even
of
resistant
Salmonella.
rate with the quinolone is higher
Yeah,
than this.
but he's saying a situation where sensitivity is there.
Even if you want to use the quinolone in the sensory report, please see that what is the surrogate marker for the fluoroquinolone.
Yeah.
That is also very important.
Sir, but nowadays the quinolone sensitivity is coming back.
No, but I agree with you that quinolone sensitivity is coming back. But I repeat that most of these patients who are sensitive to quinolone are also sensitive to cefixime or ceftriaxone. So a preferred drug would be cefixime than quinolone, especially given the fact that in pediatric practice, we are not supposed to use quinolone, especially if you have a child who is less than 12 years. Yeah.
Thank you, sir. Thank you much.
How about adding steroids too?
Oh, Pandora's box. Why? Let us ask him. When do you add steroids to enteric fever?
I have seen that if I add for a day only one dose also, that the child is happy, the parents are happy, as well as the doctor is happy.
Please, I think very loud and clear message. No steroids in this type of the situation.
But I'm
And
extremely happy
even
he's being very candid and he's voiced his opinion. Yeah. Yeah. How many of you use steroids? Okay. So in a child of enteric fever who continues to have fever despite your antibiotic, remove
Voting
four
will
or
be
five
what?
things. Four or five things. One, defervescence takes time. It can take as many as 7 days. Number one. Number two, look at the overall condition of the child. Look at the toxicity. Look at his appetite. Look out for complications. Simple thing like thrombophlebitis, developing cholecystitis or
cholangitis.
abscess, cholangitis.
Abscess.
A
Sometimes
sick-looking child, HLH, not so common,
Yes,
but
yes,
HLH can
HLH.
occur with. Then drug fever is not uncommon at all. When you use ceftriaxone to treat a fever, I know
I think
typhoid fever.
fortunately after this getting the ceftriaxone
Yeah.
or cephalosporins, we have the lesser the problems of complication.
Yeah.
Particularly suppose if the enteric encephalopathy, myocarditis, these type of the complications, even shock, yes, steroids are indicated.
Yeah.
Otherwise,
Yeah.
beyond this, I will say
Baldev bhai,
complications. then-
we have
Yeah.
too many cases and there is hardly any time left.
No,
We're going to go interact with our Nagpur colleague now. So 11-month-old girl, fever with chills for 2 days, physical examination is normal. Urine routine shows 60 pascals per high powerful urine culture report is awaited. And which one will you start? Amoxicillin, amoxiclav, cefixime, cefotaxime. Let's vote.
Yeah.
Nagpur colleague? Nagpur is online?
Yes, yes, sir.
Yes, and somebody did it.
Yes.
Myself, Dr. Shilpa Hazare from Nagpur.
Bol Shilpa. Yeah. Bolo.
Sir, urine infection, by and large, it is gram-negative bacilli. So
Yes.
I will use either cefixime as a first choice. Sometimes even amoxicillin can work. But first choice, cefixime.
Okay, let me ask you the other way around. Amoxicillin works on gram-negative pathogen. Amoxiclav also works. Cefixime works. Cefotaxime also works. So why cefixime? Or why amoxicillin only?
A general rule, sir, that any infection below the diaphragm, that is most of the times gut infections and urinary tract infections, cefixime is a pure drug which is working on gram-negative bacilli and should be used for those conditions. Why use antibiotic which works on gram-positive organisms also? Because we do not expect any gram-positive bacteria here.
Shilpa accepted. Cefixime
Dot answer,
infection
dot
below
answer.
diaphragm.
Dot
What about amoxiclav or amoxicillin?
Again,
Why
sir,
not amoxicillin?
because we do not expect any gram-positive bacteria.
But madam, amoxicillin can work on gram. Let me ask those 4 or 5 questions. What is the probable pathogen pending the culture report? You said gram-negative.
E. coli.
E. coli, Klebsiella, Proteus.
E. coli.
Yes.
Yeah, okay, E. coli. So amoxicillin works on E. coli, doesn't it?
Yes, but sometimes there could be ESBLs also.
Okay. What about amoxiclav? If you're talking about ESBL, you have clavulanic acid here.
We can
Why
use
not amoxiclav?
also can be used here, but we want to why we are sparing amoxiclav for above the diaphragm is because it works on both gram positive and negative, and below the diaphragm we expect mostly only gram negative, and so cefixime below the diaphragm.
Okay, so let me summarize what she has said. That probable pathogen gram negative, most common pathogen is E. coli. Infection below diaphragm, of the 2 thirds in oral cephalosporin, we prefer cefixime. Amoxicillin also works on gram negative, but the rate of resistance amongst E. coli it is there about 30-40%. So one would prefer cefixime over amoxicillin. Amoxiclav is a very broad spectrum antibiotic. Like your cefixime, it has a gram positive cover also. And it is again not a first preferred drug of choice. When it comes to selecting a drug for a given infection, apart from its spectrum of activity, it has to be backed by a good number of clinical trial data, proving the effectiveness of that particular antibiotic against that particular pathogen in a given infection. Okay. 3.5-year-old girl, fever for 3 days, 100 true, increasing trend, but the child is active in between, has cold and cough for 4 days, bilateral earache for 2 days, child is febrile, throat is mildly congested, left eardrum is red but not bulging, harsh breath sounds, CBC, throat swab for H1N1 or X-ray chest. What will you do here? And will you do this test? And which antibiotic will you start? Coamoxiclav, ceftriaxone, oseltamivir, azithromycin, or give only paracetamol? Let's quickly vote.
Yeah, vote.
The voting is for the antibiotic choice. Mm-hmm. Okay, majority think that this child should receive coamoxiclav. Some people have said they would prefer injectable antibiotic. About 1 out of 10 are saying oseltamivir is indicated
Because you
in this child.
mentioned H1N1.
And azithromycin, some people have said. And again, 1 in 10 think that only paracetamol should be given. Let's go back to the slide and let's analyze this patient. Dr. Prajapati, your comment.
Yeah.
First of all, my question is, would you ask for this test?
Already, I think we decide always. First, make the clinical diagnosis. On base, you can plan for the investigations. Now, on this given information, 3.5 years, fever of 3 days, fever certainly, cough, cold. I think it very definitely it indicates that likely it is viral. Bilateral earache, okay. That also can be even in a case of the viral. Febrile, throat mild congested, eardrum red but not bulging. I think that also we'll have to learn that how to examine with the otoscope, and that just red, there is no bulging. And harsh breath sounds a different story. So I think on this ground, if we come to the conclusion, it looks that yes, infection, and it is more likely viral. If one say I'm sure viral, probably we may not go for these investigations. But there is no question of the antibiotics. Yes, you can follow the patient, treat the symptoms point of view, which already we have probably done.
So probable pathogen, site of infection, severity of infection, resistance pattern, and host comorbidity. All these questions have been addressed by Dr. Prajapati, and these are the things that one would keep in mind and always look at these questions.
One message
before.
here in such patients, Ambedkar sir is, I will say, teaching us very since many years. Whatever you analyze, put the diagnosis, and I'm sure once we put the diagnosis, probably we'll have the jitteriness for investigations or even the antibiotics.
So in the interest of time, I'll wind up with this last 2 slides on management recommendation of otitis media.
I think
and,
just in case of
so
pneumonia also.
Complications more likely below the age of 2 years. That's why it is taken as cutoff for making
Antibiotics.
recommendations. It can be either bacterial or viral. Bacterial, the commonest cause is pneumococcus.
Yeah.
The second common will be non-typable Haemophilus, and then you have Moraxella. But it is said that in an immunocompetent child, it is the pneumococcus and pneumococcus only. Haemophilus usually piggybacks on pneumococcal infection. Almost always pneumococcal. Otitis media conjunctivitis syndrome is typically caused by non-typable Haemophilus. And a child below 6 months of age should be treated like a bacteremic child. There are no clear-cut, guidelines on treating otitis media in this age group. Most of the guidelines would talk about 6 months and above. 6 months to 2 years with confirmed unilateral or bilateral otitis media of any severity, the antibiotic recommendation is different. About 2 years, severe disease, the antibiotic recommendation is different. About 2 years with non-severe, and then perforated TM with oturia. So this is the recommendation. Above 6 months, if there is history of mild penicillin allergy, if there is no history, start with amoxicillin. Remember 40 mg per kg per day. Most of the Western guidelines would talk about 80 mg per kg because they have a problem of intermediate resistant streptococcus pneumonia, which we do not have. So 40 mg per kg still holds true and it works. If there is penicillin allergy, one could think of cefdinir or cefotaxime or cefuroxime. This has to be non-type 1 allergy. In type 1 type of allergy, even the other beta-lactam one needs to be a little wary. If there is failure to treatment with amoxicillin, one would change over to high dose amoxicillin. This is the recommendation made by the Delphi consensus. Now, here we are aiming to kill two birds in one stone. By increasing the dose of amoxicillin, you take care of the small percentage of children who have that intermediate resistant Streptococcus pneumoniae, and you also cover non-typable Haemophilus or Moraxella, which produce beta-lactamase. So you have double dose amoxicillin and clavulanic acid. Now 14:1 ratio is available, which is less irritant and it is better tolerated than doubling the dose of ammo. In the past, people used to add amoxicillin to amoxiclav, standard dose amoxiclav. And if the symptoms persist, you may have to admit this child and give ceftriaxone. The exceptions are otitis conjunctiva syndrome, where Haemophilus, comes ahead of pneumococcus, and then one would think of, starting standard dose coamoxiclav, and if there is failure, you switch over to high dose amoxiclav. So the difference between the old recommendation and this new recommendation is, it is almost always pneumococcal or viral. If it is pneumococcal, think of amoxicillin. You need not even think of amoxiclav to begin with. So this is the recommendation. Severe disease, one can admit and give ceftriaxone. So
I think those who are not aware, please open the 22nd edition of Nielsen. Very nicely they have given this table and we can follow it.
And please do not use high dose amoxiclav for pneumonia, for your garden variety, otitis media. There are definite limited indications for using high dose amoxiclav. Now we will skip this case, and Dr. Prajapati wants to take this last case and we'll stop here. Yeah, go ahead.
No, they want.
Yeah.
This was a 6 years boy, high grade fever, 101, 102 degree for 4 days, cough mild, fast breathing 2 days, chest pain right side, vaccinated as per the national program. These were the vitals which you can see with the fever, some signs of on the right side with RNT diminish and vocal resonance increase, and these were the investigations. Even the X-ray chest was here, and the options for the treatment, which antibiotic should be given. I think let us go for the voting.
Yeah.
We'll discuss.
A common scenario.
Very common. And purposefully taken for
Let's
conveying
vote.
the
Let's
exact
vote.
message. Please. Yeah, I think voting started.
Voting started?
No,
No.
it does not work. Yeah.
Yeah. Start.
Let us try to know from them. Anybody, I will say from any center, Dr. Vijay?
We have a divided house, but though majority are saying
Not divided,
amoxiclav.
multiple
I mean,
divisions.
Sir, the drug of choice for this child would be amoxicillin plain. This is a garden variety of community acquired pneumonia, which is not non-serious, and the classical, the typical organism is staph pneumoniae, and it responds very well to amoxicillin. Drug of choice, amoxicillin.
Dr. Sanjeev speaking from Indore.
Yes, yes.
Yes, sir.
Sanjeev,
Yeah, but
let us
Dr.
give
Dr.
others a
Sanjeev,
chance.
Dr. Sanjeev, you can see amoxicillin only 5.8%.
Yes, sir, but that is the correct answer.
So I think the
Sure.
respiratory chapter has to work very hard because the message has not gone
let's
to
go
the
back
people.
to the slide. Yeah. So here is a case of lobar pneumonia, a child who is 6-year-old and has had fever for 4 days, and there is definite pneumonia. So, Dr. Prajapati,
I think-
why amoxicillin?
I think
Why
just
not
to,
amoxicillin?
just to save the time,
Yeah.
just go one or two slides. Next slide. For convincing, I will say, explanation. Please try to follow these things. We don't have here probably we will not have the answer in culture or somewhere. All of us know that practically it is not possible. But then we can follow this science or knowledge that according to the age, consider the most common organism. Coming with this table, I will say more than 5 years, child was 6 years. So probable organism, again, we follow what Vijay has started. Looking at the age, probable organism, then I think streptococcal pneumonia should be the most common. Yes, if you find the difficulty, mycoplasma may be the second, and very specific, probably some manifestations may consider the staph. So I think here with this picture, first consideration will be of streptococcal pneumonia. Then the next question comes, what should be our choice of antibiotics? For that, can you go for the next slide? And again, here, if you see it, more than 5 years, even the amoxicillin is still drug of the choice, but somehow, Dr. Vijay, because it has been reflected in the voting, in the practice, something is different. That's very certain. And I will say at all the places. And believe me, this time only I have given the one dissertation to my students. One paper we had of few patients for the presentation, but this time more than 150 cases we are going to study what is the role of, because it was quite encouraging in our 30-40 patients. And even one of the articles which has been very categorically mentioned that cephalosporin somehow we are getting attraction for the treating, but amoxicillin works very
But
well.
only one point, this is applicable to patients who are being treated on outdoor basis. For an inpatient, one would still use either coamoxiclav or injectable
Indoor patient is
ceftriaxone.
different story.
On OPD basis, it will be amoxicillin. And there are valid reasons. The third gen cephalosporin, cefpodoxime, Dr. Shilpa mentioned for infections above the diaphragm, prefer cefpodoxime or cefdinir. But the bioavailability, protein binding, and the pharmacokinetics are such that amoxicillin fares much better than third gen cephalosporin when it comes to treating a probable pneumococcal pneumonia. So let's go. I mean, I can't resist but tell this story. Ahmedabad only, I was conducting a workshop on antimicrobial stewardship, and a similar case was shown. And the one of the attendants got up and said, "Sir, my answer here is amoxicillin, but in my chamber I use coamoxiclav."
That's why I said
that is the problem, that let's
Dissociative
have some courage, let's have confidence in amoxicillin. And that is the whole purpose of conducting such sessions, that think of probable pathogen, site, severity, resistance, host comorbidity.
Even
If you go home with these 5 questions to be asked every time you pen down an antibiotic, and of course, fever, unless there is infection, but there can be non-infectious fever. All infections are not bacterial infections. There are some self-healing bacterial infections. And once you think that it is a bacterial infection, and once you decide to use an antibiotic, please answer these 5 questions. I think let's stop here for
we'll
a
have
of
to
time.
stop. We'll have to stop.
Thank you so much. It
Thank
was
you.
wonderful
Thank you.
interacting
Thank you.
my virtual audience
Yes,
also.
Just one point. This child was actually sick, had respiratory distress, and actually was
So you are right. We made it clear that if child is to be admitted, one would definitely prefer coamoxiclav.
But I
because
think
here,
again,
yeah.
Dr. Vijay, if you look at any child of pneumonia is going to have the fast breathing. But if you see the increased work of breathing, that patient even does not come in the category
Yeah,
of that.
she said distress.
Yeah, distress. So
Yeah,
that patient certainly, once you have the courage, if you start the amoxicillin, if you treat it, I'm sure that you'll be convinced that yes, we can treat this patient with oral amoxicillin.
So one final message: have faith in amoxicillin. It is a wonder drug. Your group A beta hemolytic streptococcus drug of choice, amoxicillin. Otitis media drug of choice, amoxicillin.
Amoxicillin.
Pneumococcal pneumonia drug of choice, which is the commonest pneumonia, is amoxicillin. So please resort to using amoxicillin.
Thank you very much.
Thank you.
Thank you.
Thank you, sir.
Thank you, Dr. Yivale and Dr. Prajapati, for this inspiring and insightful session. So, moving on to the last but not the least session for tonight, that is airway diseases beyond asthma. For this particular session, I would like to welcome Dr. Kaustuv Mohite, consultant pediatric pulmonology, interventional pulmonology, and sleep medicine. He has been awarded with many prestigious awards and has been the youngest European Pediatric Respiratory Society diplomat in 2021. He has been the ERS mentor for consecutive 2 years and has over 16 original research and chapters published in national and international peer-reviewed journals. I will now request our senior ALChem members to kindly felicitate Dr. Mohite. I will now request Dr. Mohite to kindly take over the session. Thank you.
Okay, so good evening, everybody. I know everybody is very hungry. I promise I'll not take more than 20-25 minutes, but let's make it a point that whatever we learn today, whatever less, whatever more, we'll make it efficient and we'll make it worthwhile. Who's this? Yes, this is the very famous William Shakespeare. And he says, the eye sees all, but the mind shows us what we want to see. In a crowded OPD of 100, 150, you have multiple types of coughs coming to you, and here you are confused, which is what? And how do you treat them? Do you use the same medicine? Who do you give oral? Who do you give nebulized? Who do you give injectables? In such state, you have to make sure that you're delineating the common from the uncommon. And here is my talk about airway diseases other than asthma. Now, to make things very clear, all airway related or all lung related disease could be mainly categorized into three parts. Either it is your airways, your alveoli, as in your parenchyma, or your interstitium, which is the connective tissue of your lung. And if you just clinically differentiate these three, just focus on the main problem. Your airway comes with wheezing, cough, shortness of breath, probably sudden in onset. Your alveolar, gradually in onset, may have some respiratory related disease, some difficulty in breathing. Interstitium, again, a slow progressive disease having more of hypoxia, chronic related events. Now, knowing this, all airway related disease have main two problems. It's the cough and respiratory effort. What Ambedkar sir used to tell us is all the cough receptors predominantly saturated in your upper airway. As you go down, the density of receptors go on decreasing. And just by saying that, your laryngeal pathology will have significantly more cough as compared to your lower respiratory tract pathology. And based on that, different kinds of cough, whether it's a wheezy cough, a stridorous cough, a barking cough, or a whooping related cough, also tells you the anatomy of cough. So more or less, clinical features, examination clinches the diagnosis of what kind of cough you're dealing with. The second thing is respiratory effort, especially the retractions. The site of the retractions also tells us grossly which anatomy is involved. Now, knowing this, just make it very easy. We can divide our respiratory system into three parts: upper airway, proximal lower airway, and distal lower airway. Now, the upper airway mainly comprises of your nose, nasopharynx, oropharynx, and your larynx. The proximal lower airway is your subglottis and your trachea, and your distal lower airway are your primary bronchi on your bronchioles. Now, let's find us specific disease pathologies which could present based on the anatomical malformations. So this is the first case. A 3-month-old child, a late preterm, 36-weeker, birth weight of 2.4 kg, complains of fast breathing, noisy breathing, and feeding difficulty, progressively increasing since birth. Now, this is a very early onset. So this is first take-home point. Very early onset, think something different. This is how this child is breathing. You can see significant retractions, subcostal as well as suprasternal. He's tachypneic, significant retraction, there's significant failure to thrive. Query syndromic, you can very well appreciate the retrognathia as well. Now, how do you go about? Clinical impression, yes, there is something which is obstructing the upper airway, but what is it? The most common thing that we know is something called as laryngomalacia. But not all kids with these problems have laryngomalacia. And there comes the importance of upper airway assessment. Here, if you see that the epiglottis is nicely opened up, your arytenoids are also nice and not flopping inside, but the whole of the pharynx is being pushed behind, and that is causing the obstruction of your laryngeal inlet. This has been termed as pharyngomalacia. Note, major difference, laryngomalacia is the loose epiglottis or your arytenoids which are going inside your laryngeal inlet. Pharyngomalacia is dynamic compression because of the structures around the larynx. And if you just Google pharyngomalacia, you'll find nothing because it's not well documented. You do a deep dive and there are very less articles, especially the one from Iran, where he mentions that it is a dynamic obstruction of the air column proximal to the glottis. And in wide variety, it is often missed because most of the pulmonologists in these cases do bronchoscopy from the oral airway. And once you put your scope from the oral, you obviously miss because you're entering through the pharynx. In these cases, you have to enter through the nose, and that makes a point that you have to use that appropriate size scopes. So in this 3-month-old child, you have to use a 3 or a less than 3 millimeter scope. In severe cases, the treatment is tracheostomy because you have to bypass the whole thing in order to make this child breathe normally. So your first is pharyngomalacia. Let's get to the second case. It's a 5-month-old child, complains of noisy breathing, progressively increasing. Progressively increasing respiratory efforts, has coughing, vomiting episodes during feeding, and again not gaining weight. This is the way he's breathing. You can hear the stridor. It's actually biphasic stridor, both inspiratory as well as expiratory. This child is irritable. You have an audible stridor, you have a suprasternal. You have a suprasternal as well as subcostal retraction, but not much tachypnea. The earlier child was tachypnic as well. So here is approximately more than normal the respiratory rate, but not significantly tachypnic, maintaining saturations on room air. Here, again, which would be the best investigation of choice and which would be the worst investigation in this case? X-ray practically of no use because again, you're dealing with an upper airway. There's something which is dynamically obstructing. So X-ray will not yield anything. CT, again, that wouldn't be the first thing because again, you're expecting something which is upper, proximal to your laryngeal inlet. Ultrasonography, interestingly, in this child, I specifically mentioned about ultrasonography because ultrasonography, yes, did clinch the initiation of diagnosis. And finally, yes, being a pulmonologist, I have to promote. Again, don't take me wrong. I don't put scopes in all kids, but here is how scopes makes differences. So just a simple ultrasonography, put your probe on your larynx and you find nice cystic lesion sitting there. Probably that is causing your upper airway obstruction. And knowing this, you go ahead and do a bronchoscopy to find a nice vallicular cyst which is obstructing the upper airway. With every breath, this vallicular cyst is causing compression of your epiglottis, somewhat causing complete obstruction of your airway. Now, obviously, this child needs to be treated, and so CT was done. And here you can see a very nice cyst sitting on the vallicular fossa, which is causing dynamic upper airway obstruction. So immediately, the definitive management is surgical, which is marsupialization, and immediately post-surgical, the distress is gone. So subcostal retractions are gone. This is immediate post-op child. So what is a vallicular cyst? It is again a rare benign laryngeal cyst which develops at the base of your tongue. It consists mainly, it's a retention cyst and formed by obstruction of mucus gland and has most of the mucinous content. So again, once you operate it, the chances of recurrence is significantly low. So here is your vallicular cyst. Next is a 6-year-old boy, hospitalized with the diagnosis of dengue HLH, had prolonged intubation, extubated well at the time of discharge, but after 15 days has difficulty in breathing, has biphasic stridor, progressively increasing again retractions, and this is how he's breathing. Again, you can hear there is biphasic stridor. He has stridor on both inspiration as well as expiration. Having known that there was a significant past history of intubation, there becomes iatrogenic cause of upper airway obstruction. And what would be the specific modality? It would be definitely a scopy, which shows you a membrane-like subglottic stenosis. Because of prolonged intubation, because of significant irritation, the child starts, during extubation, the child will be moving, and that causes local injury, which causes subglottic membranous stenosis. And knowing that it is stenosis, the treatment becomes endoscopic only. Here, this child went balloon dilatation, and again, after dilatation, this upper airway was nicely opened up, and you can see post-procedure, immediately again, the whole stenotic stricture was gone. So the child who was breathing like this, with the procedure taking not more than 45 minutes, was like this. So there is no stridor, no retractions, breathing comfortably. Again, long-term prognosis, yes, they could again regenerate granulation tissue, but that is something that we have to take with a pinch of salt. We have to explain the parents that this might recur, but with proper medications, with proper inhaled as well as local steroids, that also can be taken under control. So we've learned about subglottic stenosis. Now, moving down to the trachea, this is a 7-year-old child, well-grown boy, has episodic coughs in the last 2 to 3 years. No aggravating or relieving factors, multiple oral inhaled medications given, but no significant benefits. And this is how he coughs. All permissions were taken before taking videos. So this is how he coughs. Once he has this episode, has silent cough. So again, the barking kind of cough tells me grossly what anatomy could have been involved. Again, can we determine the anatomical origin? Yes, of course. Just based on the cough, it has to be proximal airway, somewhere midline section. This X-ray, any help? Yes, no? Just one wild. Is it of any help? Yes, it is. I will tell you why. Go inside because of this cough, suspecting a tracheal anomaly. Go inside, you find a nice tracheal pulsation at the distal segment of the trachea. You can see from the proximal, it's fluttering, which is coordinating with your heart rate. So there is some arterial obstruction which is causing external compression of your proximal airway, causing this cough. And with this, go back to the X-ray. Can you see something deeper? There is one fine shadow, again, not very apparent on your screen, but once you take a film, fine shadow, which could have been picked up just based on an X-ray on CT, was right-sided aortic arch with an aberrant subclavian artery. So this was causing obstruction, and you give how many ever medications, you give anything. This is an anatomical malformation. This needs to be surgically operated. So this was operated. This was the vascular sling which was being created, which was released, and this child, the cough just vanished away. You definitely need to give some anticholinergic nebulizations to make sure that the malacia gets better over a period of time, but that was very well taken care of. So this is an external vascular compression. So all these things which could have been treated as recurrent asthma, have multiple different causes. Coming to the next case, this is a 6-year-old boy, has 4 episodes of pneumonia, multiple antibiotics received in both OPD and IPD, all pneumonias predominantly affecting the right upper lobe, has failure to thrive. And these are the X-rays. Serial X-rays only affecting right upper lobe. When there is multiple times you are affecting that the single part of the lobe is being affected, there has to be some anatomical malformation that has to be ruled out. And in this child, if you realize, let's not go into the CT, the bronchoscopy, this child has something called a tracheal bronchus. If you see the angulation, that is the most common site where mucus plugs can plug in, and that could cause recurrent infections of that very site. So based on the degree, there are different kinds of tracheal or pig bronchus. It's called pig bronchus because it's a normal anatomy in pig lung. But based on this, if it is very high and causing recurrent infection, it needs to be lobectomized. So a tracheal bronchus. Next, a very common case, yet missed. This case was actually Yevle sir's case. So this is a 4.5-year-old girl. Complaints of persistent wet cough, intermittent noisy breathing, intermittent episodes of low-grade fever, spikes. Complaints, all these complaints started from 3 years of age. Before that, this child was apparently fine. So from 3 to 4.5, last 1.5 years has intermittent episodes of on and off waxing waning cough. Not gaining adequate weight in the last 1.5 years. Received multiple antibiotics, after which fever subsides, but cough still continues. There are no extrapulmonary complaints. Mild baseline tachypnea, chest symmetrical, no retraction, auscultation, has monophonic V's. Again, importance of monophonic V's, very difficult to appreciate, I agree, but still that could give us multiple. So a monophonic V's gives you more of proximal airway involvement. And this is how the X-ray looks. You can see that the right lower lobe is collapsed consolidated, and that has been the same thing again in the past X-rays. CT also showed the same with localized bronchiectasis. Now, having known that there is only one lobe involvement with the rest of the lobe completely fine, again, there has to be some airway anatomy, some retained foreign body. And this was a cap of a pen, which was taken in 1.5 years back. Luckily, it was hollow. And so this child was breathing even through the cap of the pen, which was, the air was passing through it. But eventually that needs to be removed out. So a retained foreign body. Finally, this is a last case, a 7-year-old female child, complains of cough for the last 6 months, persistent runny nose, recurrent episodes of fever, recurrent ear infection, not gaining adequate weight. I'm giving you all clues to get to the diagnosis just on the first slide. So this is how she coughs. Again, wet sounding cough. Predominantly in the morning hours, more on exertion, and occasionally greenish expectoration. Persistent nose block with query mass-like protruding from the nose, frequent ear pains with one episode of ASOM, and complaints of passing hard stools. Now I'm just giving off the diagnosis. 2nd-degree consanguineous marriage, and first child was lost. So there is some genetic predisposition as well. Both weight and height are less than third centile. You can see the mass protruding, probably a polyp, and there is some degree of clubbing present. So bilateral polyphonic wheeze was present, bilateral basal creps were heard, and this was the X-ray. Anything abnormal? Yes, one thing abnormal, the X-ray was wrongly placed. There's dextrocardia. So now everything becomes very obvious with dextrocardia, with bronchiectasis, and polyp. This is PCD, primary ciliary dyskinesia, very commonly missed as asthma, treated as recurrent asthmas. So it's caused by either absent or abnormal motility of ciliary lining, causing lining in multiple tubular structures. The main problem is stagnation of secretion, and hence it involves multiple organs. There is a holistic management requiring multiple subspecialties. A pediatrician, pulmonologist, ENT, a gastroenterologist, as well as dietitian do all play equal role. So you've seen just by the anatomical site of different airway pathologies, you could differentiate them from your usual most likely asthmas. So one last take home point, if at all I want you guys to take, is when not to think asthma. First, very early onset early age of onset, failure to thrive with recurrent or persistent vomitings, difficulty in feeding, so aerodigestive problems, continuous wheezing, which is not responding or requiring multiple medications, localized lung findings, presence of fixed monophonic wheeze as we saw in the previous case, abnormal chest X-ray findings, or CVS findings, other system involvement, severe chest deformity, which is showing you a chronicity of the event, hypoxia in the absence of respiratory symptom, showing towards a cardiac probable cause, and finally, no associated typical triggers or response to your usual bronchodilators. So even if you rule these simple steps out, you can rule out your most common reasons of calling them as an asthmatic, and you could clench your diagnosis, which is not an asthma. Sorry, sir. Yes, sir. Friends of clubbing, showing the chronicity of event. Thank you. Any questions? I'll be happy to take. Thank you.
Thank you, Dr. Mohite, for this excellent session. So, as we come to the end of Accord Pedia Summit 2.0, we will have to extend our heartfelt thanks to everyone who contributed to its success. Yes, we would like to thank our distinguished faculty, our chief coordinator, chairpersons, and moderators who have been in Mumbai and across India. And we would like to thank all the participating pediatricians. Your enthusiasm and engagement have surely made this Accord Pedia Summit truly special and memorable. So thank you for your dedication to excellence in pediatric care. We look forward to your next gathering. Thank you.
ठीक है मैं अभी इसको बैग में रखवा देता अभी सर रखवा आप कहीं हैं बात हमारी बेगा मारी